Brenda. I'm the Strategic Partnerships and Capacity Development Manager of EDCTP. And I'm going to introduce the session for our emergency COVID funding program of EDCTP, which started yesterday. Thank you all of us that have joined us today in this very important discussion and sharing of information of our contributions to this pandemic that is ravaging the world, as we all know. So without much ado, and apologies from my Executive Director, Dr. Michael Makanga, who is not with us today, but we have here very nice presentations from eminent colleagues. We will have 2 sessions this afternoon, like we did yesterday, chaired by 2 different co-chairs, one following another. In between, we'll have a small break, and there will be also panel discussions. And towards the end, we'll have a closing from our High Representative of EDCTP, Dr. Leonardo Simao. So just a few housekeeping rules. Please keep all your microphones on mute, except for the chairs and the presenters. And for the presenters, when it's your turn, please turn on your camera if your bandwidth can cope with that. If that is a problem, you can please keep it muted or blacked out. So without much ado, let me introduce the chairs of the first session. We have Charles Wasongi from the Medical Research Council here in South Africa, whom most of you know very well. He's also linked to GROPIDAR and many other initiatives that are to do with public health and emergencies in Sub-Saharan Africa. The co-chair for the session is Professor Veronique Penlap from the University of Yaoundé 1. She is also a well-known member of the EDCTP family. She has been on several committees of EDCTP, and she's also part of very important consortia, ALERT, and also CANTAM, that are all working in this area of finding solutions against epidemics. So I'll hand over to Charles to take us through the first session and liaison with Veronique. Over to you, our chairs.
Thank you so much, Tom, and thank you for inviting us. So, like you've said, Charles Shea Wisonge. I work for the South African Medical Research Council, where I am the director of the Cochrane Center, Cochrane, South Africa, and I'm also a co-chair of GROPIDAR. And I will ask my co-chair, Professor Penlap, to introduce herself before we start the session. Over to you, Veronique.
The University of Yaoundé 1, head of the TB Laboratory and Pharmacology, head of the Clinical Biology Institute here at the Catholic Central African University. I've been members of a lot of commission within EDCTP as TB expert consultant and other consortium. And thank you for inviting me here.
So thank you so much, Veronique. So this session is going to be on COVID-19 and other major infectious diseases in Sub-Saharan Africa. And our first speaker is going to be Ida Sivro from Caprisa, South Africa. And I will ask Ida to first make and present, do an introduction, and then talk about the consortium, and then do the presentation. Over to you, Ida Sivro.
Thank you so much. I hope you can see my slides. So I'll be presenting on the part of the HALT COVID-19 team. It stands for Natural History and Laboratory Tests for COVID-19 in South Africa. And this research is based at Caprisa in Durban in KwaZulu-Natal. So as you all know, tuberculosis, HIV, and COVID-19 are all pandemics with ongoing sustained community transmission across all continents, but especially in Sub-Saharan Africa. And when we wrote up the proposal, we expected, as many other people did, that the COVID-19 patients that are co-infected with TB and HIV will have a much poorer treatment outcome, and that the overlap of the three diseases will lead to a significant increase in mortality and morbidity across Sub-Saharan Africa. So in order to address this, we had several research objectives. We wanted to characterize clinical disease progression and clinical outcomes among individuals with SARS-CoV-2 viral infection in Sub-Saharan Africa. We wanted to characterize the immune responses in the context of various co-infections, and we also wanted to validate some of the new diagnostic tests for SARS-CoV-2 and COVID-19. Sorry. So we started a cohort. Like I said, it's based at KwaZulu-Natal. It was based at an urban setting, and specifically in King Dinuzulu Hospital and the KwaMashu Community Health Center. We were specifically targeting ART clinics, TB clinics, and flu clinics. And patients were offered the SARS-CoV-2 RT-PCR, and the patients that tested positive would then get enrolled into the study within 3 days following screening. And then we had follow-up at day 7, day 14, day 28, and then later on at month 3, 6, 12, 9, 12, and 24. And during the follow-up, we were collecting a wide range of specimens that we're planning to use for future immunological investigation, and obviously for clinical diagnostics as well. So when it comes to COVID-19 and HIV infection, initial reports especially, and majority of the currently published studies actually found no significant difference in clinical presentation, adverse outcomes, or mortality between HIV positive infected individuals and HIV uninfected individual COVID-19 patients. There was a study from Cape Town that did see a increased risk in HIV infected population as well as TB population, where the increased risk was around twofold. However, other studies coming from Spain and even China did not see any differences. And while there were some recent preprints on coming from Alex Segal and Al Leslie's group at ARI, looking at immune responses, specifically cellular immune responses in HIV-infected and uninfected COVID-19 patients, detailed immunological and virological studies are still lacking. So just briefly to show you what was happening with COVID-19 in South Africa, we had a very quick government response to the pandemic. We had a national lockdown that was instituted in March. And because what was expected, obviously, is that due to the high burden of HIV and TB in the country, that we would experience very significant surge in cases. And that actually didn't happen because we had a very relatively mild first wave. And there are several reasons for this, why this happened, but we had a very strict lockdown measures at the beginning, which is one of the contributing factors. Recovery rates were over 98%, and we never really went over 12,000, more than 12,000 cases in the whole country a day. We started our study at the end of the first wave around 23rd of July, when we started enrollment into our study, and we just stopped the enrollment end of February at the end of the second wave. So the second wave in the country was much much more severe, and this was mostly driven by the fact that the lockdown measures were obviously lifted. This was happening over the holidays, so there was a lot of big spreader events, student parties, lots of people traveling and moving around, and also the emergence of the new variant, the B1351, that was identified in Eastern Cape and then quickly spread across the country. So currently we're around 1,500 cases per day. Our positivity rate at this time is around 5%, and our recovery rate is like around 95%. That never really went below 85% in the country, even during the second peak. So overall in our study, we screened over 2,000 patients, and we enrolled 110 patients that tested positive for COVID-19, and out of those 34 were also HIV co-infected. And while we have stopped enrollment at the end of February, we are obviously still doing follow-up. So this table, I'm just going to show you some of the preliminary analysis we did in the last week, and this table just summarizes the cohort characteristics. So you can see that the age groups generally our patients' age range between 30 to 60. As you would expect, the risk of previous TB episodes and current TB was higher in the HIV-infected patients, and this is expected that HIV is a driving factor for TB. We actually didn't identify lots of HIV or lots of COVID-19 TB co-infected patients. We only had 4 patients, despite specifically targeting TB clinics. We just did not see much overlap between the two diseases in our population. Generally, majority of our HIV-infected participants had controlled viral load, and majority of our study population was presented with very mild symptoms. So they were either mild, some were asymptomatic, and some moderate, but we had no patients presenting with severe COVID-19 symptoms. So irrespective of HIV and TB status, newly diagnosed COVID-19 patients were clinically stable and presented with very mild disease with minimal clinical progression. We even had a patient who had drug-resistant TB and was also had advanced HIV disease, and he also presented with very mild symptoms. And interestingly, he remained RT-PCR positive for SARS-CoV-2 during the entire follow-up, and this is something that I'm going to discuss later. So we also looked at risk of hospitalization. Like I said, due to the moderate and mild nature of COVID-19 disease, we didn't have a lot of hospitalization events. However, when we did analyze the risk, what was to be expected, diabetes was the driving factor of that led to risk of hospitalization in COVID-19 patients. The low CD4 count was also identified as a risk factor for hospitalization. And we also included a variable wave just to look at the difference in variants. And what was actually shown is that the first wave had higher level of hospitalization, and this really had nothing to do with biology or the variants. Is basically what happens during the first wave. There was a lot of hospital capacity, and we experienced much milder peak than what was expected. So anybody that tested positive for COVID-19 would be hospitalized, whereas the opposite happened in the second wave, where our hospitals were full and there was no capacity. So then even patients that needed to be hospitalized, if they were moderate, would be sent home with oxygen simply because there was no hospital beds. So 6 of our patients were asymptomatic during the entire follow-up, and all of them were HIV uninfected. And the days before screening, the first symptom observed ranged between -1 to 37 in HIV uninfected group and -7 to 79 in HIV infected group. And I just want to bring it, this was one of the challenges we encountered, especially in HIV co-infected patients and TB co-infected patients. It was very hard to distinguish COVID symptoms from non-COVID related symptoms in this population. You're dealing with patients that are generally not in the best health and that experience frequent episodes of general symptoms like cough and fever. So it becomes very difficult to time the COVID-19 disease accurately. First thing we wanted to look at was whether there was a difference in CT values between HIV infected and HIV uninfected COVID-19 patients. And I stratified this across the disease timing. And we really didn't see any obvious statistically significant differences between the two groups at the same time points. However, when we looked at percent detectability over time, we found that HIV infected patients were consistently higher, that percent detectable CT was consistently higher in HIV infected patients, pointing towards lower viral shedding in this population. And we identified 23 patients that had that were RT-PCR positive with a CT value less than 25 for more than 14 days. And there were also several patients that had CT values below 15 that were past 40 days post-symptom onset. So it does seem that the co-infection, especially the HIV co-infection, affects the length of viral shedding. Another thing that was measured at each study visit was the presence of SARS-CoV-2 IgM and IgG antibodies, and we did this using the Orient gene rapid test. There were a few patients that tested negative for both IgM and IgG during the entire follow-up. However, when we looked at differences in presence of IgM or IgG between HIV infected and HIV uninfected patients, we did not see any obvious differences between the two groups. We also looked at, we measured some of the inflammatory markers at the enrollment, specifically CRP and D dimers that were previously associated with disease severity, and we did not see differences between HIV infected and HIV uninfected COVID-19 patients. And this was irrespective of whether the CT was detectable at the visit or not. So in summary, we observed no differences in clinical presentation of SARS-CoV-2 viral load between HIV infected and uninfected participants. Percent detectable SARS-CoV-2 was consistently higher in HIV infected patients over the 28-day follow-up, potentially pointing to longer viral shedding in this population. And our study, like I said previously, we stopped study enrollment at the end of February, and we are currently in the process of cleaning up and finalizing the analysis. We have several ongoing studies. We are doing the sequencing of our SARS-CoV-2 variants with Dr. Tulio Oliveira at CRISP, specifically focusing on these long-term viral shedders to look for interperson viral evolution over time. We are looking at inflammatory markers analysis, and we have student projects looking at SARS-CoV-2 specific plasma and saliva antibody levels, as well as analysis of SARS-CoV-2 specific T-cell responses. And we have an ongoing project with FIND to evaluate the new rapid antigen diagnostic tests in South Africa. And finally, I just want to thank my CAPRISA COVID-19 team, the study participants, all the funders and collaborators, and especially our lab team who has worked incredibly hard during these very stressful times. And thank you all for listening.
Thank you so much, Aida. And Veronique will introduce our next speaker.
The second presenter is Kwame Shanube from Treat COVID Consortium that had called to introduce himself and say a word about the consortia before presenting in 15 minutes what we want to show. Over to you.
Thank you so much and good afternoon. So my name is Kwame Shanauve. I work for Zambat, and I am presenting on behalf of the Treat COVID Study Consortium. The Treat COVID Consortium consists of Zambat, the London School of Hygiene Tropical Medicine, the University of Oxford and Sheffield, as well as KNCV. So the title of my presentation today is Understanding the Epidemiology of SARS-CoV-2 and the Interrelationship of COVID-19 with TB and HIV in Zambia. So the rationale behind and the main objective behind our study was really to measure the prevalence and the spread of SARS-CoV-2 in Zambia, working with one urban community and extrapolating to the wider population using mathematical modeling. Our specific primary objectives were as follows. We wanted to measure the prevalence and cumulative incidence of COVID-19 disease. We wanted to measure the seroprevalence and seroincidence of SARS-CoV-2 infection, and we wanted to measure the interrelationship between COVID-19 and TB and HIV. In addition, we wanted to conduct contact tracing and testing of household contacts of confirmed COVID-19 cases and follow them for the development of symptoms and disease. We also wanted to conduct social science research that will improve our understanding of SARS-CoV-2 transmission patterns, disease severity, and risk factors. So the Treat COVID study is an observational epidemiological study with 3 linked sub-studies. It is linked within the Treats project. The Treats project aims to determine the impact of a combined TB-HIV prevention package on TB outcomes. In terms of the Treats COVID study, the target population is the whole population of individuals aged 15 years and above in Gungubwacha in Kabwe, and Kabwe is in Central Province in Zambia. The study duration is 8 months. We started in July last year, and we are still doing field work. In terms of the sub-studies, our first sub-study aims to look at the cumulative incidence and prevalence of symptomatic COVID-19 disease. All individuals aged 15 years and above living within the study community are eligible for inclusion in screening for COVID disease and subsequent diagnosis of disease. The first sub-study will enable us to measure the cumulative incidence of COVID-19 disease in the total population among individuals aged 15 years and above over 6 months. It also allows us to measure the point prevalence. In the second sub-study, we aim to look at the seroprevalence and seroincidence of SARS-CoV-2 infection. In this sub-study, a random sample of 4,000 individuals aged 15 years and above was invited to be tested for the presence of antibodies to SARS-CoV-2 at baseline and will be followed up for 6 to 12 months. In this sub-study, it will give us a proxy of past infection as well as community transmission. The third sub-study looks at diagnosed 19 COVID cases and household contact tracing. In this sub-study, all confirmed COVID-19 cases are followed up and all household contacts of all ages of positive COVID cases are enrolled and tested for COVID-19. So for our field work, all members of the community are invited as long as they meet the eligibility criteria. So we screen all members of the community aged 15 years and above using COVID-19 symptom screen and temperature check. Individuals with a positive screen are invited to go to the clinical site where the activities I've shown in the slide are conducted, including testing for COVID using VITA-PCR, TB screening, and expert testing, as well as testing for malaria. For individuals that have a negative COVID screen result, they are invited to go to the mobile field site, where at the mobile field site, we have already enrolled a random sample of 4,000 individuals aged 15 years and above. And in these individuals, we've tested them for antibodies to SARS-CoV-2 at baseline, and we'll also follow them for 6 to 12 months. So I'm going to share our very early preliminary results. So far, we have invited 8,415 individuals coming from 2,563 households. Out of those individuals that were invited, the consent rate is 54%. Out of the individuals that agreed or consented to take part in the study, 98% were screened for COVID, and about 11% had a positive symptom screen. So 337 people were seen at the clinical site, and out of these, 96% had a swab taken. And out of the individuals that had the swab taken, the prevalence for COVID disease was about 7.7 at this stage of the study. So this slide shows the distribution of symptoms among those screened positive for COVID-19. I spoke about a COVID screen, so this just summarizes the questions that we're asking. And as you can see, the commonest symptom was any dry cough, followed by a self-reported fever in the last 5 days. As our sub-study 2, in our sub-study 2, we looked at a seroprevalence survey, and I'm going to share our preliminary findings as well. We have not finished analyzing this data, so we've only tested approximately 18% of samples collected. So samples were collected from participants visiting either the mobile field site or the clinical site between November 19th and November 19th and November 30th, 2020, which was really between the first and the second wave in Zambia. We administered a standard questionnaire to look for potential risk factors for infection. We also did a serological test that was performed on plasma. Anti-SARS-CoV-2 antibodies were detected using Abbott IgG assay, which was performed on Abbott Architect automated analyzer. So what we found was that overall, about 12.7% of individuals tested positive for IgG antibodies. And as you can see from the map, we've also seen very few clusters around certain areas of the community. So these preliminary findings really indicate that between the first and second wave of the epidemic in Zambia, there has been continued transmission of infection. We are hopeful that by the end of April, we're going to have full results from this seroprevalence survey. Here I'm going to share some of our qualitative findings that have been finished from this component of the study. So the broad brush survey, which was done in August last year, aimed to inform community engagement processes and study implementation. So I've summarized our brief findings in 3 themes: awareness, response, and impact. So we knew at the time that we did this piece of work, people were aware of COVID and the public health measures, but there was very little evidence in terms of disease in the community, which led to conspiracy theories about the origin of COVID and who really had disease. And there were also some comparison with HIV. However, there was heightened awareness of hypertension and diabetes. And in regarding with response to COVID, there was partial adherence to preventive measures. And we saw that preventive measures dropped off just before the end of the first wave. And there was also a stigma in the community and fear of pain of the tests. There was, in terms of impact, one of the most prominent impact that we observed was avoidance of health facilities. There were social tensions in households that were relayed, including domestic violence. Some women appreciated actually men being more available in the households. And down there, I've included a quote which was done by one a community advisory board member, really showing that lead to very limited evidence in terms of disease in the community. Here I've summarized some of the publications that are ongoing in relation to this study. We're hopeful that in this next quarter, we should be able to publish our qualitative work as well as the result from the sero-prevalence survey. And we've continued to promote the study nationally and internationally. And there I have indicated some of the platforms that we're using for this. And I would also want to point out our collaboration between BOTNA and EDCTP, which is really looking at an improved way of active case finding using digital technology in Lesotho and in Zambia. So lastly, I would like to thank the TRIS COVID Consortium for conducting the study. I would also like to thank the TRIS Consortium, which is responsible for implementing the main study. And thank you very much for listening.
Thank you, Mr. Kwame Shanube. Thank you for this presentation. This brings us to the third presenter, Ahmed Landry Bashiboyu from Untitled COVID-19 Consortium. Can you introduce yourself and then tell us about your consortium, please? Over to you.
Thank you. I'm Ahmed Bachi, and I'm MD and PhD candidate for Fondation Congolaise pour la Recherche Médicale, which is located in Brazzaville, the capital of the Republic of Congo. And we work in this project as part of a sponsorship of COVID-19, which stands for Integrated Testing Approach for Laboratory Training and Strategy Against SARS-CoV-2 Spread in Brazzaville. And we conducted a sero-prevalence study on asymptomatic subject that we intend to share with you. Sorry. Well, a sizable number of coronavirus subjects are asymptomatic. This has been mitigated since the beginning of the pandemic, but now it has evolved to become a serious public health concern. And in the meantime, we see most countries, including countries of Central Africa, they resort to a massive screening of subjects who are only symptomatic. But mild cases in asymptomatic subjects are discarded from screening policies most of the time. And in the same time, what we know is that in those countries, precisely in resource countries, having so much testing tools is still a challenge. For example, in the Republic of Congo, we have seen a slight growth in testing capacity, but it is still limited. And it makes it difficult for us to evaluate the spread of the disease because we only focus on symptomatic subjects. Brazzaville and Pointe Noire are the most affected cities in Brazzaville. Brazzaville is the political capital, and Pointe Noire is the economic capital. Both cities have respectively 6,180 for Brazzaville cases and for North 2,375 cases. And the World Health Organization recommended for countries like Congo the use of RT-PCR for the diagnosis of SARS-CoV-2. However, it is an expensive way of diagnosing patients because it requires adequate facilities, trained human resources, and electricity, which is a serious problem in resource-scarce countries. However, RDT, which stands for Rapid Diagnostic Test for the detection of antibodies, SARS-CoV-2 antibodies, has proved to be a practical alternative for diagnosis of subjects, SARS-CoV-2 subjects, and it is relevant to determine the course of the infection, seroconversion when RT-PCR sensitivity has decreased, and it is helpful to inform public health stakeholders on the development of herd immunity within the population, as now vaccination is taking the first place in many health policies. The objective of our study was to evaluate the incidence of SARS-CoV-2 within the Congolese population, asymptomatic subject residing in Brazil, by conducting a seroprevalence pilot study. The study was conducted in Brazil, as we say, and we included subjects at the Fondation Congolaise pour la Recherche Médicale Health Center from April to July 2020. It was a cross-sectional study by an open invitation screening, and we collected RNA samples and serum samples from asymptomatic individuals, and we recorded their medical history, and samples were stored at -80 before analysis performance. SARS-CoV-2 was detected, RNA was extracted using the QIAGEN protocol by following the manufacturer's instructions, and PCR were considered positive when CT values were below 40. IgM and IgG detection were detected using qualitative detection tools, which were two different rapid diagnostic tests to minimize biases by following the manufacturer's instruction. We obtained a side consent by patient before starting the study. Statistical analysis were proceeded using the following softwares, and p-value was considered statistically significant when it was below 0.05. This method allows us to have the following results. Out of the 754 individuals recruited from April to July in Brazil, the mean age was 39.69, with values ranging from 2 to 9 years old. And out of those 754 subjects, 56, equating to 7.44%, were found to have active SARS-CoV-2, out of which 9.3% were males and 4.5% were females. This prevalence was associated with gender, but not associated with age. And the most affected region of Brazil was Mongali at 80.1%, but there was no significant difference. Out of the 754 patients subjects enrolled in our study, 149, 90%, were found to have at least one activity. And when we tried to make the distribution of the disease throughout time, we found out that the prevalence was increasing over time, and it was slowing between May and June, regardless of PCR results. And women were found to have more exposed to the virus by having a high level of IgG or IgM with comparison to male, regardless of RT-PCR results. It was the first study reporting SARS-CoV-2 seroprevalence in the region in Central Africa. It was a pilot study, and we conducted this cross-section study because we wanted to know to estimate the proportion of the Congolese population who was exposed to the virus. Some studies have been conducted in July and in August, respectively in Kenya and Malawi, but their results were a little bit lower than what we found in Congo Brazzaville, meaning that the Congolese population was very exposed to the virus. And when you try to see in the result we displayed in the screen, it's like 15% of our cohort was RT-PCR negative, but having antibodies in their serum. Of course, the United States had nearly twice our result because it's the most affected country so far. And as you said, the objective here was to estimate only the proportion of Congolese population who has been exposed or in contact with the virus along the course of the infection, including the lockdown period we had. And therefore, all participants did not present any symptom of the disease. And the findings show that a significant part of the community harbored asymptomatic infection. And 7.4% had active detectable SARS-CoV-2. And when we try to make the calculation by adding 15% who were RT-PCR negative but having antibodies, we equate this to 22% of the Congolese population who have been infected through the course of the pandemic. And as we say, this study showed that a minimum of 50% of participants were self-converting from April to July. In April, we had only 2%, and in July, it peaked to 22%. And from May to June, we had the country lockdown. And as we saw in the result, during that time, the infection was lowering. Some studies have reported that lockdown period may have an impact on the surge of the disease. But in our study, it was difficult to have such conclusion because we did not know, information on situation before lockdown, the number of diagnosed cases before lockdown. So it was difficult for us to have the same conclusion. Our results, we've said, present high prevalence of SARS-CoV-2 antibodies, much higher than reported in Wuhan, which were 3.35%, meaning that Congolese population is very exposed. And when we try to make the calculation according to the Brazzaville population, it meant that 1 out of 5 inhabitants was in contact with the virus. Mungali was the most affected district as confirmed by the national screening of symptomatic cases, but we found no significant difference in geographical distribution of the disease. Nevertheless, this high seroprevalence of 18.1% in this district would be partly due to the non-compliance with mitigation of containment measures in this urban area with intense business activity. Such observations have been made in a business district in Brazil also. The limitation of our study will be attributed to the selection biases because subjects were enrolled based on the fact that they felt themselves as being at high risk, either in contact or they tend to see themselves like being likely to develop the disease. And also the second limitation of the study was that we used immunochromatographic assay instead of immunofluorescence assays, which has better sensitivity. In conclusion, our study called into question the hypothesis that the virus is only transmitted by a symptomatic subject. We see that even asymptomatic subject may be responsible for the progression of the disease. Thus, this data suggests that urban transmission through droplets, aerosols is also involved while talking. Here, the need for the compulsory and appropriate wearing of the mask as long as the pandemic flags is still important. Our results were published in the International Journal of Infectious Disease, and we thank all partners who finance our research. Thank you.
Thank you, Ahmed. for this presentation. I will then call for the three panelists who just presented to put on their camera, if possible, and also those who did not present to introduce themselves and say a word about the consortia they represent. I'm talking about Aida, Kwame, Armel, Yves, Nathalie, Hamed, and Lisa. I hope you are all there. Thank you. So Charles, over to you.
Thank you so much, Veronique. So, Dr. Wahed, maybe you could introduce yourself and talk about the consortium you represent.
So, many thanks for this very nice presentation. We are the Consortium of Africa Suitcase, and it's actually from the name, it's a suitcase. So we have developed a suitcase lab where we can detect SARS-CoV-19 and also other viruses in less than 30 minutes using an isothermal amplification technology. We are happy to hold the record of the maximum number of African countries involved in a project. So we have 7 African countries involved in the project: Nigeria, Ghana, Senegal, Congo, Madagascar, Uganda, Sudan. They are all involved in our team to evaluate this rapid diagnostic test in several African country, and together we will do it with Institut Pasteur in Paris. So this is our consortium, and I'm so happy for collaboration and welcoming the questions.
Thank you so much. And let me go over now. I see Nathalie is represented by, not Nathalie, right? Yeah,
thank you. Yeah, it seems too obvious to all of you that I am not Nathalie. My name is Laurent Fraisse. I'm replacing Nathalie, who had the obligation to, I would say, she couldn't simply join to this meeting. I would like to thank the organizer for the invitation. I'm actually the head of research and development for Drug and Related Disease Initiative for the NDI. And I'm representing, in fact, in activity we are conducting in for COVID-19, a consortium that we have together with other partners launched last year. At the end of the last year, the consortium is called Anti-Cov. It's a platform trial that will occur in 13 countries, so Burkina Faso, Cameroon, DRC, Equatorial Guinea, Ethiopia, Ghana, Guinea, Ivory Coast, Kenya, Mali, Mozambique, Sudan, and Uganda. So many partners, many sites dedicated to finding new treatment for mild to severe cases of COVID-19. I'm happy to take any question about it as well. Thank you.
Yes, thank you so much. Yeah, and thank you for replacing Nathalie to represent your consortium. Yeah, and Professor Lisa Hall.
Hello, everybody. I'm speaking to you from Cambridge, UK, and our consortium AfriDX is together with Noguchi, Kumasi, KNUST in Ghana, and the Danish Technical University. And we are primarily looking at the way in which we can develop a production process for local manufacture at low cost and allow a holistic on-demand production of test kits. I think in the last presentation, we heard in the Congo the lack of availability of reagents. So perhaps we will have a solution for you. We're taking a prototype point of care nucleic acid isothermal test for detection of viral RNA, and which is produced by the Danish Technical University, and that's being tested in labs in Ghana. And then we're replacing the reagents, hopefully, with the reagents which will be produced locally. We're also screening and isolating single chain antibodies for serological tests, so that we can combine both the point of care nucleic acid test and the point of care serological test, so that you've got the kind of end-to-end testing that can be manufactured locally at low cost and without significant capital investment, and produced on demand and used locally.
Thank you. And would Yves Levy, who is representing Yves Levy? Would that be you, Professor Andres?
Hello, everybody. I'm not sure if I'm the one, but anyway, I'm here. And I'm representing a consortium that is looking at BCG vaccination to prevent severe COVID-19. Not quite sure how it fits in here, but anyway, our partners are from Sweden for the statistical support, and there's a group in Aragon in Spain that is doing very interesting laboratory experiments with BCG, and we have a few local collaborators here that help us finding the participants. So we have found 1,000 people between May and November last year that we vaccinated with either BCG or a placebo, and we are still collecting data. The follow-up is 1 year. So I don't really have any results to present. It's for us interesting to have seen the data accumulate over the first wave and the second wave. So I do know about the overall number of events and how we collect them, but I do not know if the BCG vaccinated people or not vaccinated people had the events. That will only be known to me at the end of observation period, which is in November this year. Well, that's what I can say. Thanks for including me here, and thank you for having me listen to the interesting presentations.
Okay, thank you. So we'll watch that space, and come November or later, we'll hear from you. So we've had very interesting, there's a lot of interesting discussions going on in the chat. But for now, we had some questions for the panelists. So let's start with the first question that I wanted the panelists to really talk to is what would be, and I know for those who have presented already, you can still add, but maybe the newer panelists, what is the impact of COVID-19 pandemic on other major infectious diseases in Sub-Saharan Africa? And maybe I could start with, could I start with you, Lisa?
Yeah, I feared you might start with me. In terms of testing, I think the thing which came out for me in the presentations that we've heard is the need to have testing available and the need to be able to respond quickly to test not just COVID when you have a pandemic uprising, but also to be able to test the other diseases which are already ongoing. And one thing that I didn't hear, but I have heard from colleagues that I work with in Asian countries, is that the care of the patients with malaria, the patients with TB, and other infectious diseases has decreased during this pandemic. And because the cost of testing is too high for individuals to be able to test, then that's just disappeared. And there's beginning to become a significant concern that we are losing patients with these other diseases because the ongoing care has been compromised by the attention to COVID.
Thank you so much, Elisa. And Ahmed, what would be your view regarding that, regarding the question around the impact of COVID on other diseases?
So actually, I will not speak about direct impact about the diseases. I'm working from the testing point of view, as Liz said. So we are in the same, I think, bucket list. So what I would like to say is that we have a big problem of delay in delivery of the reagent we would like to have. All the factory, all the people are busy of producing COVID-related stuff and just ignore all other needed stuff for other diseases at the diagnostic level. We have also a problem of, and I must say that this is the shame. I'm speaking only about Germany, but also you see everybody say Germany did quite good at the beginning of the outbreak, but they have also restricted exporting many stuff which needed for other stuff. Yeah, this is really a shame unfounded from the German government of restricting delivery of necessary stuff like disinfectant or other stuff, or needed for not only for COVID, about needed for also for other diseases. But saying that, I need also to tell you something. On the long term, the winner will be not COVID. I think the winner will be the other neglected disease and other endemic diseases, because the awareness of disease increased. Real-time PCR machines becoming everywhere. In the old days, we was searching for real-time PCR machines in a specific country or a specific region, but now it's everywhere. Most of the people have been trained to do diagnostics, so we have more people actually involved in diagnostics. And also we have more people aware of diagnostics, because I must admit that in the formal days, if you told everybody I'm working diagnostic, they tell you, oh, yeah, this is not interesting field. But nowadays we know that diagnostic is very important part of our life. So what I would like to say is that now we have a delay for all our programs for chikungunya and dengue, that people just ignore testing against these viruses and just focus on COVID-19. So we have delays, and I'm sure that will continue also this year, but will improve. But on the other hand, on the long term, I am sure we will have enough experiences and machines in order to do in the long run combat diseases or eliminate diseases.
Thank you so much, Ahmed. And before I hand over to Veronique, I would ask for, based on this question about the impact of COVID pandemic on other diseases, maybe the point of view of the Anti-COVID Consortium, and then I will ask Ida and Amel before I hand over to Veronique. So let's see what the perspective is from Anti-COVID.
Thank you. So, you know, I'm part of an R&D organization. It means that I'm considering the impact a little bit like the former speaker, Dr. Amit, on a long-term point of view. And that's important because my perception, our perception, is that there may be impact, of course, short-term for the current patients suffering from NTD, but also for the future patients, positive and negative as well. From a DNDi point of view, we are suffering from impact in our current clinical trials that will probably delay the delivery of new treatment for patients suffering from neglected tropical disease. At phase 1 level, at also field trial level in Africa. So those are significant impact. We have been, of course, been impacted by having our staff being affected by COVID-19. But in parallel, we have been able to complete some important trial like one for leishmaniasis with a combination of paromorphine, metefosine as an example, we moved to a digital follow-up of patients during the period. That is definitely also a progress for the future. And I share the view about the fact that having multiple PCR machines everywhere in many places in Africa will be helpful for many other trials. I'm thinking about our sleeping sickness trials in the future. Having PCR on site will be extremely important. So that's a clear impact we are perceiving. The second one is about the fact that in order to provide and deliver fast and affordable responses to the COVID-19 crisis for low, I would say mild to moderate cases in Africa, the drug we are testing and many are testing are very often coming from the antiparasitic area. I would just mention ivermectin, amodiaquine, or nitazoxanide. So there may be also an impact in the near future if one of those drugs become active. Then there will be, I would say, we will have to be very careful at manufacturing level not to impact, in fact, the populations that need those drugs for negative tropical disease, like onchocerciasis for ivermectin, in case ivermectin will be used as well for preventing patients suffering from mild or moderate cases of COVID-19 infections. So that's a different level of impact I just wanted to highlight and to complement the previous comments that have been made. Thank you.
Okay, thank you so much. And I would just invite also the panelists to look at the chat. There are some interesting questions there, and some of those you can just answer directly. And I don't know, Ida, do you have any additional comments to make apart from your presentation?
Yeah, I think I would just like to make, I mean, we already see a reduced number of people getting tested for HIV, and I think I'm a bit more pessimistic when it comes to the impact of COVID on HIV and TB, because what I think is going to happen in the next couple of years, we're going to definitely see an increase in HIV incidence simply due to lack of testing, which means that you have undiagnosed people, you know, with more transmission, people that are not on ARTs, people not showing up for the ARTs because of the lockdown or because they are afraid to go to the clinic or go to the hospital because they're worried they're going to contract COVID-19. So I think a lot of the great progress we've done in the last few years with HIV is going to be diminished by COVID. Another thing that I think it's very important to highlight is that I've obviously COVID is a priority now globally, but we have seen decreased in funding for other diseases like HIV, TB, or malaria. And that is going to have a massive impact on these diseases in the future, the research for these diseases, the progress that's going to be made with treatment and prevention. And that's very unfortunate because I think especially on the African continent, we need to remind ourselves and remind the rest of the world that the biggest killer here are TB and HIV. It's not COVID. More people are dying from TB, more people are dying from HIV, and that has to remain priority. And I think even within our research units, we really need to sort of, while we obviously want to contribute to the COVID-19 response, we have to keep our focus and we have to keep pushing our HIV and TB agenda.
Thank you. And Amir, do you want to add anything?
So you speak to me, Ahmed, yeah? Right, yeah?
No, Amel Bachi.
Oh. Ahmed, you know? My first name is Ahmed, so it's very difficult.
Okay. Yeah.
Okay, so the Dr. Ida has said everything, because TB, HIV, and chikungunya account for 200 million people each year globally and kill more than 2.5 million. And our laboratory traditionally concentrated this research on those diseases. But since the beginning of the outbreak, we have recalibrated our expectation by including COVID-19 research. And unfortunately, what we see is that COVID-19 is eroding the traditionally funding that we had for those tropical diseases, and it's become a real problem because research in tuberculosis seems to stall, and HIV also research seems to stall. But we're doing our best to strike the balance by, progressing in COVID-19 research and our tropical diseases research, because we are the one who live our tropical diseases. So we have to do our best to improve things and to, bring meaningful contribution in this area. And there's even an article published by the director of our foundation, of the Congolese Foundation for Medical Research, who is consigned to me. She published an article on Science on last November, which was entitled, "What if tropical disease had as much attention as COVID-19?" And she described really how we Africans have to really, strike the balance between improving data on COVID-19 and still be focused on resolving our own public health issues.
Okay, thank you. Thank you, Emil. And Andreas, do you have any additional comments on this?
Yes, thank you. I do. I'm trying to share a screen, and can you see a funny graph with blue lines and red lines? I hope you do.
Yes, we can see it.
So, okay, we are a tuberculosis research site here in Cape Town, and this is the number of, TB tests that in the districts where we recruit from have been submitted. And this speaks to the impact, on TB and HIV that was mentioned. You can see that this spans from January 2020. The average is something between 30 and 40 per unit of time. I think it's weeks here. And then the lockdown came in April, and the testing dropped to something like 30%, even though logically tuberculosis is unaffected by TB. People no longer went to the clinics. And once it started opening up again, you see that spike, on the right side about September, October. And it seems that it's not actually going down to the level where it was before. So we still see an increased number of people being diagnosed for tuberculosis now 6 months or more after the lockdown was lifted. And I think this has been described in model projections, about what would happen to tuberculosis if people are not attending the clinics the way they did before. And I think it's a small sample here, but we can see exactly what was predicted. And I'm sure there must be similar graphics about HIV and other healthcare measures that suffered from the COVID lockdown. Thank you.
Yeah, thank you so much for that, showing the impact on services from the disruption from COVID-19. So the impact is both at the biological level, but also at the service delivery level for these diseases impacting on COVID and COVID impacting on them. And I will hand over now to Veronique to continue the discussion with the panel. Over to you, Veronique.
Okay, thank you so much. We'll ask the panel to come to this second part of the questions and give their response and their comments. What can be learned from other disease programs and adapt to COVID-19 testing, prevention, and treatment approaches? What can be learned from other disease programs and adapted to COVID-19 testing, prevention, and treatment approaches? Over to you for the panelists.
Okay, so I want to add, based on our experience, I think what can be learned from TB and HIV, having worked in this area for a while, for us, what is very evident is the role of true community engagement, and the need to use community-based approaches. We know that during the lockdown, people could, as a lot of people have pointed out, they could not access drugs for TB and HIV. So there's need to use, home-based delivery of drugs for individuals that are at home, in the same way in which, there's been a lot of focus on the HIV cascade. We can learn also the trace, screen, test, and isolate cascade for COVID. And we know that at each one of these steps, in as much as there are challenges, we know that there are opportunities as well. We can also learn, from doing contact tracing for TB, we can adapt some of those lessons to COVID. And something which is very close to our heart here at Zambat is stigma work, which we have been doing. Like I mentioned in my presentation, some of our work, our COVID work in this community was really hampered by stigma, which we had to address. And this is, very similar to what we experienced, I think, at the beginning of both the HIV and TB epidemics. And then the other point, of course, is the need for a multi-sectoral approach. We know that private sector partners can provide technical solutions and digital health solutions that are important. I didn't mention, there was a question in the chat regarding what diagnostics we're using. And some of those diagnostics have actually come, from FIND, they've come from DELF, who have been very invaluable, who have made an invaluable contribution to the study. And lastly, just to emphasize on the need for an integrated approach. Yeah, that's my contribution.
Okay, thank you. Dr. Hamid.
So what I would like to say is that in implementing diagnostics for eliminating neglected tropical diseases, we have implemented novel technologies, which in the former days was not easy to convince the people to use it. But nowadays it's very easy after COVID to convince the people to use it. But the important point I would like to stress here that we need to think, especially in Sub-Saharan Africa, and for that I like the project from Lisa a lot, is that we need to encourage, and I'm here, I hope you make my voice also to the EDCTP, that we need to encourage local production for diagnostics. This is a must in the coming months and the coming years. This is because if there is no local production, the problem of little testing will continue for longer time.
Thank you. Natalie?
Well, I'm comfortable if you continue to call me Natalie, even if my first name is Laurent.
Ah, yes.
This is okay, no problem.
Laurent.
I'm very happy with that.
Laurent,
Natalie is a close friend, so this is absolutely
oui, allez-y, Laurent, allez-y.
No, I think for me, we learn a lot, and I will just give you two key words for me: repurposing and platforms. Many drugs that have been used for neglected tropical disease have been repurposed from other areas. Ivermectin, again, is an example. It has been used in animal health. We are developing other drugs that are coming from the animal health area. We are using drugs in COVID trials that are coming from HIV or hepatitis C area. So the concept of being fast in trying to develop affordable solutions with easy to use and affordable drugs have been widely used for neglected tropical disease and is currently the only short-term therapeutic, potential therapeutic option for COVID-19. And the second keyword is platform. At least from our point of view at DNDi, we always try to collaborate with a network of clinical sites and scientists in Africa in order to set up a clinical trial and to, I would say, put the clinical trial at the right level of size in order to produce, I would say, a statistically significant response for a disease. It's very clear from the COVID-19 results that 80% of the trial do not have the capacity and the size that is sufficient to produce actionable data. And what we have conducted with the consortium Anti-Cov is not very different from what we did on leishmaniasis, what we did on Chagas disease, what we did on sleeping sickness, meaning creating I would say cross-country platforms to develop the right size of clinical trial and to test our therapeutic options. Thank you.
You need to unmute. You need to unmute.
Can I call for Haida, Yves, or Lisa if they are still around?
We're still here. Yeah,
Yes.
I think I agree with the previous commenter. His comment is basically that there's a lot of stigma, and I think we should apply some of the lessons we learned from HIV when it comes to COVID, just increasing testing. Like we experienced that in our cohort where people would just, they didn't want to know, they didn't want to test, or they didn't want clinics, nurses coming to their house for follow-up visits due to just fear of being, prejudiced and being judged by their neighbors. And yeah, I think there's lots of lessons we can learn that go both ways. I think for HIV, we can learn a lot from COVID new techniques that are being used to develop vaccines and things like that. So I think there's lots to learn either way when it comes to HIV or TB or any other disease and COVID. Thank you.
Okay, thank you. Yves, if you are still around, Yves. If not, Armel, for your comment, if you are still around. Armel, if they are not around, then I will give the talk to Charles to continue. Over to you, Charles.
Thank you very much, Veronique. And Lisa, did you have an additional comment to make? The question asked by Veronique. Mm-hmm.
I think probably the other panelists have covered everything that I would say. There was a very big report in 2019, before we knew about the world of COVID, about testing for HIV and different models of testing. And the conclusion there, which is not unexpected, it makes total sense, is that the faster you test, the better the outcome and the lower cost overall, if one wants to look at it in a healthcare economics view. And that was the sort of general conclusion, and the way in which it was perceived that had to happen was that self-initiated testing had to be a goal. And I think that's something that we are seeing certainly in Europe and the States, that self-initiated COVID testing is something which is enabling better test and trace. And I think that is a lesson that isn't going to go away. And the drive, as Ahmed was saying, the drive for testing, the acceptance of testing, and the importance of testing will be a legacy from COVID. But you still have to overcome the stigma, and that shouldn't be underrated, how difficult any any testing, any label that's put on somebody, how big an effect that can have on them in all forms of social interaction. In some age groups, to have a label of a particular disease, of course, will potentially prevent them going out and partying with their friends. In other cases, it will ostracize them from other members of the community. So I think we really have to think about that and think how to overcome that stigma of the label.
Thank you very much, Lisa. And I think the issue of stigma is a very important one we should not take care of. There have been various questions in both the chat and the question and answer sections. There was a question around community-based approach and community involvement to deal with epidemics, which Kwame responded to. Kwame, do you want to talk about that? And then also to answer the question around the range of diagnostics that are being used in your study in the urban setting.
Yeah.
Kwame? Mm-hmm.
Yes, so the question was community-based approaches for epidemics. So, I mean, we have a lot of literature on community-based approaches in non-epidemic situations. So I responded in the chat, this is when we're actually coming up with approaches that are strictly linked to epidemics. A lot of our work has been based in non-epidemic situations. And then in terms of diagnostics, so we are using quite a number of diagnostics for testing. We are using, like I said in my presentation, we are using PCR, Vita PCR, which was really a struggle to get, I must say. And then we're also using Expert Ultra and the antigen test, the rapid test. We've also, Delft is one of the consortium partners. They very kindly, through their support, we've been able to do CAD for TB and CAD for COVID as well. And we're helping them determine the clinical threshold for research purposes. And then we're also for antibody testing, we're using Abbott Architect. Yeah.
Okay, thank you, Kwame. And I think these have been very interesting discussions. We could go till morning, but in the next 5 minutes, we are going to round up. But there's one question that came up from the audience, and I think either Kwame or Amel could be able to answer. Let me start with you, Kwame. Do any of your panelists have data on COVID and chronic malaria co-infection? In malaria endemic regions, is a sensitive malaria assay also being considered at the time of COVID diagnosis? I will start with you, Kwame, and then I will go to Amel, if you have any comments on that.
Yes, so we are collecting, we're actually testing for malaria. It's one of the tests that we're doing. But so far, we have not had a lot of study participants that have malaria. As you see, we still have the number of people that have COVID is not so big. So among those, we do not have any study participants that have both malaria and COVID at this point.
Thank you, Kwame. Amel, around malaria and COVID. Do you have data on that?
We do not, at the time that I'm speaking, we do not have any data on co-infection, but we are intending to conduct a study to see co-infection including malaria and COVID-19. It is because malaria is a disease that we are started working for a decade now in our laboratory, and we intend to conduct a study to see the co-infection.
Okay, so with this, I will really thank our panelists very much for this interesting discussion, the presentations and the discussions. And we've seen that there is some kind of two-way relationship between COVID and various diseases, both at the biological level in terms of outcomes, that it might impact the outcomes, but also at the service delivery where the pandemic has disrupted some of the services and has probably led to more morbidity and mortality because the services could not be offered. They have been disrupted by the COVID pandemic. And I will ask Veronique to, yeah, to you.
Okay. Thank you all for all your comments. This session 3 today was focused on COVID-19 and other major infectious disease in Sub-Saharan Africa. And for the take-home message, considering all the presentation, we can say, to summing up the discussions, that HIV-mediated immune dysregulation that has a huge impact on the length of viral shedding. We also notice that prevalence is associated with gender, but not with age, from the study that have been conducted in Congo. And no correlation between the clinical presentation, considering the co-infection between COVID-19 people infected with TB or HIV. There was an increased risk for severity among people having HIV and those that were infected with TB, and no clinical or radiology progression between the two groups that were mentioned. They indicated that there were no significant difference between COVID, TB co-infected patient or COVID, HIV co-infected patient, considering the clinical different value. No significant difference between AGM and AGG SARS-CoV-2 in HIV positive and HIV negative groups. No difference also were mentioned and observed considering the inflammatory marker from the preliminary study that were already conducted. And concerning the brainstorm for question 1, care of patients having TB and malaria and other diseases were very decreased during this period. And that they observed that we're losing patients with these other disease, and all the focus was only on COVID-19 patients. And this impact also come to the delivery of reagents and the exploitation of all the material that are used for the following, to follow up the other disease like TB, malaria, and non-neglected disease. And they also observed that a part of this negative observation, RT-PCR and other techniques that are actually used in the case of COVID-19 are openly installed, implemented area, increasing the number of trained people that are very aware of how to diagnose, very well trained now, increasing the capacity building in many of our sites in Africa. So the experience in capacity to follow up this type of disease have been increased. And the TB people attending all the services in the majority of health centers have been really observed that it was decreasing. That was really the most impact that was observed, especially in Cape Town. And concerning the last question on how the other disease program can really transfer to COVID-19 testing, prevention, and treatment approach, their experiences. They talked about new technology coming, local production for reagents and testing methods are also encouraged, so that they can also encourage repurposing drugs that can be used for for the new treatment, and then increase the panel of drugs that can be used in the operational activities. That collaboration with network also is within clinical trials also is really something that can be increased to really increase the level or the quality of the response that can be brought by the different researchers. That healthcare in terms of economy also should be really put in consideration, and develop the self-initiative testing also to be encouraged. And that can enable the increasing in the level of testing, and then to enable the population to be tested and really to be taken into follow-up in the different health center. So I don't know if Charles has another comment to bring to add to what I just said.
No, Veronique, you summarized the session very well. It only remains for me to thank the panelists, to thank the audience, and to thank EDCTP for giving us this opportunity for these discussions. Over to you, Tom and Pauline.
Thank you, Charles, and thank you, Veronique. I can't thank the chairs much more and the panelists for this very enlightening session. And the messages are very clear that COVID has made our work more complicated, but all is not lost. In those complications, there are opportunities that we need to exploit together. So at this hour, I think let's have, we were supposed to have a 15-minute break, but I would request that we have a 10-minute break instead, so that we come back at a 1:45 the hour. So let's have a biological break, and then in 10 minutes, I'll introduce the next set of chairs. Thank you very much, everyone, for your participation.
Thank you.
Thank you.
Hello and welcome to Kenya. My name is Francis Dungu, an EDCTP Senior Research Fellow working on the immunology of tropical diseases. EDCTP currently supports my work in 3 key projects. The first one is in malaria immunology. The second one is a large multi-center vaccine study, and the third one is in COVID immunology. Right now, the COVID immunology project is the center stage as scientists all over the world come together to share knowledge and tackle what is an acute global problem. So what we're trying to understand is why some people get severe disease upon infection with COVID, while others remain asymptomatic or only get mild symptoms. We are also generating data on the kinetics of the immune response over time from Kenyan patients, just to determine how long the immune response to COVID lasts. We would also want to compare the immune response in COVID patients in Africa with those immune responses from similar patients matched by age and gender from Europe, because we know in Europe the frequency for severe disease and death is much more than in Africa. There are not many studies published on this subject in Sub-Saharan Africa, and we hope to be the first to publish a study correlating the kinetics of the immune response in COVID patients with the degrees of disease severity. These are really exciting times scientifically amid what has been a global disaster.
EDCTP, or the European and Developing Countries Clinical Trials Partnership, as you know, is a public-public partnership that involves institutions from both from Europe and from Sub-Saharan Africa that are mandated by their governments in collaboration and with support funding from the European Union to support the acceleration of clinical interventions or medical interventions in the fight against poverty-related and neglected infectious diseases.
Well, welcome everyone. I think that's us ready to start. Tom's smiling, so I think it's fine. Great.
Yes, yes, indeed. Yes, indeed. I didn't want to rush everyone from the biological break, but yeah, so it's 2:45. If you are around, then I'm happy that we can start. So once again, welcome everyone to these interesting discussions about this deadly disease that is deadly in many ways, as we saw from the last session, how it affects us biologically, systematically, and funding-wise, and whatever complications these have come. And we are here to discuss these things as we have dedicated our lives to making the world a better place in terms of eradication and treatment of diseases. So the next and last session is about new emerging questions, such as long COVID, new variants, and knowledge gaps specific to Sub-Saharan Africa. And to take us through, we have two eminent chairs in Rebecca Grice from Epicenter in France, and Gail Carson from the United Kingdom. They will introduce themselves properly as I hand the session over to them at the moment. Our chairs, the floor is yours. Thank you.
Thank you very much, Tom, for a lovely introduction. Perhaps I could ask my co-chair, Rebecca, to introduce herself first.
Hi, everybody.
Rebecca, you're on mute.
Activate. Sorry, everybody. I just wanted to start just by thanking everyone, and especially Jean-Marie, and thank you very much, Tom, and of course, Gail, for all of the interesting presentations thus far and for inviting us to participate. So my name is Rebecca Grace, and I'm the Director of Research at Epicenter, which is both in Europe and across Sub-Saharan Africa.
Super, and it's an absolute pleasure to share the virtual podium with Rebecca again. The last time I think we did that was a number of years ago in Paris for reacting. So it's a pleasure to have that opportunity again, and thank you, Jean-Marie, for that. So I'm Gail. I'm a consultant in infectious diseases by background. I work across a number of groups with ISARIC, Alert and Pandora, and members of our clinical research network, administratively based in Oxford. I'm also part of the scientific secretariat for GLUPADAR, which is a consortium of funders, and I work there with Charles and Jean-Marie. And also I'm the deputy chair of GOARN, the Global Outbreak Alert and Response Network. So I know some of you through that as well. So it's great pleasure for us to co-chair this final session because I think there's some critical issues to consider, and we really look forward to the panel discussion as well, as many funders and researchers across the world are trying to reflect on what's happened in the past year regarding the pandemic, and to refocus some of our research and our investments going forward to make sure that we learn as much as we can about COVID-19. Now, I'd like to invite our first speaker, Marta Nunes from WITS in South Africa, to tell us about their work in surveillance among healthcare workers for SARS-CoV-2. And we certainly know that this has been another global concern regarding the pandemic. So over to you, Marta. Thank you very much.
Hi, everyone. Really thank you, and excited to present to this panel. And yeah, I hope probably next time we'll all be in person in some exciting place. So I'm going to share my slides. So just to make sure that you can see my slides.
Yes, thank you.
Thank you, Gail. So as Gail said, the title of our project is Surveillance Among Healthcare Workers for SARS-CoV-2 Infection, and I am the coordinator of the consortium, and I am based at the University of Witwatersrand in Johannesburg, South Africa. So with me, this consortium, there are my collaborators from the Institut Pasteur in France, and another collaborator from the Oxford University in the UK. And we have 5 work packages. The first 3 work packages are led here in South Africa, and are really about these 3 work packages that I'm going to tell you today. And the last 2 are, well, the number 5 is also ongoing at the moment, and number 4 has been a bit more delayed, and it's really just because of all the traveling and the problems that with lockdowns has been incredibly difficult to ship samples outside of the countries. And I think this would be something that probably would be interesting to discuss, the challenges that some of us are facing with the different projects and the coordination of the different projects. But so then a year ago, when we put together this project, really the main objectives was to investigate the epidemiology of SARS-CoV-2 in healthcare workers, because it was really the population that we knew would be at higher risk of infection. And exactly a year ago, when we put the proposal together, most of the projects, or at least most of the project we knew, most of the literature that was slowly coming out, were focusing on hospitalized cases. So we really wanted to understand more the whole spectrum of disease for SARS-CoV-2. So we thought that looking at the healthcare workers would be a good way to start. And something that we wanted to do was really to test our cohort, our population, independently of presenting with symptoms or not. So really to study the whole spectrum of disease of SARS-CoV-2. We also aim to look at the duration of shedding of the virus. We were planning to undertake seroepidemiology studies, so looking at the antibody response to SARS-CoV-2, and then also looking not only at humoral immune response, but also at the cell-mediated immune response, and then really do some modeling exercises to compare the burden of disease among healthcare workers in our setting compared to the general population in our setting, and also look for risk factors. So our study design was following the cohort of healthcare workers in a very rigorous way and in quite intensive follow-up schedule. So we asked the participants in the study to come every week or every 10 days, and we would have a nasal swab collected and tested for PCR. We asked the participants to try to do self-collection swabs, and that worked quite well. But yeah, not everybody agreed, but yeah, most of the samples collected were self-collected. Then we collected also a lot of information on demographics, risk factors, and medical conditions. And at every weekly visit, we were repeating the questionnaire to ask if something had changed. Then about once a month or something, we would collect a blood sample, and that blood sample was to store plasmid and to look for immune responses. Then something that we introduced a bit later in the project was to collect a baseline PBMCs to look for baseline immune response to SARS-CoV-2. And this was really the plan that we had a year ago, probably to do the study for about 4 months in South Africa until the end of the epidemic. But then the end of the year, as probably most of you know, in South Africa, there was a new variant of the virus that was detected, and basically what we decided is to continue following up this cohort. So we are still following up most of these participants, and indeed we are trying to enroll a few more to look for the burden of disease due to the new variant in South Africa. Once we detected a participant in our study that was PCR positive for SARS-CoV-2, this would go into a more intense follow-up, and we would collect samples every 2 to 3 days to really look for viral shedding. And then we also ask them to come at monthly intervals, so it's still ongoing, these monthly intervals follow-ups, where we will collect blood to look for the decay of the immune response after infection. So we were able to enroll 396 healthcare workers. These were distributed across 5 departments in our hospital. So something that I forgot to mention, we are based in Chris Hani Baragwana Hospital in Soweto. This is the biggest hospital in Africa, and the healthcare workers in this hospital, they were really happy to participate in our study. So it was quite easy to enroll these about 400 participants. Here's just some characteristics about the participants in our study. Most of the participants were from the internal medicine department, and indeed this was done on purpose. One of our hypotheses was that the internal medicine staff, because they were in closer contact and they dealt in more often with COVID positive patients, one of our hypotheses that this group from the internal medicine department would be at higher risk of contracting COVID compared to staff from other departments. 71% of our participants were Black African, 83% were females, and the mean age was 38 years. Something interesting was that the majority of the participants in our study received influenza vaccine in the previous season, and this is not really quite often like this in South Africa. I think it was really because at the beginning of the COVID epidemic, people were incentivized to have the influenza vaccine. And so it was really good to see that at least 50% of our population had been vaccinated. So I want to show you the number. So this graph shows the number of enrollments in the gray line is really the number of enrollments across time. So we were very lucky that we enrolled in a very short period. In 2 months, we enrolled all the participants, and then the bars are just the number of visits conducted. And then in the black line are the number of cases, and the number of cases was really concentrated in July, August, and this really mimics the peak of the epidemic that we saw in South Africa. And like I said, now at the beginning of 2021, we continued the surveillance, and we are already detecting some cases, although because of funding and other resource constraints, the follow-up now is not as intense as it was in the beginning. So during the follow-up period, so these are results of our data until October, so until the end of the first wave of SARS-CoV-2 in South Africa. So overall, we detected PCR positive swabs in 137 participants, so for a positivity rate of 35%. And this is much higher than what has been described in Europe and in the US. And as expected, the staff from the internal medicine department had a higher rate compared to other departments, even if we do a stratified analysis by the other departments individually. So staff from the internal medicine department, more than 50% had PCR confirmed infection during the period until October. Like I said, we also collected blood samples, and so far the blood samples that we tested were the samples collected at the enrollment, so collected in April, May, and then the samples collected at the end of the first wave in September, October. And when we tested these samples, so at the enrollment, most of our participants did not have antibodies. So just to prevent some questions about our testing, so this is a in-house Luminex testing, and we are testing for RBD antibodies only. We also have a full-length spike testing, but currently we are just doing RBD antibodies. So at the enrollment, we had already 4 participants that had antibodies detected, and then at the end of the follow-up, we tested again the samples for antibodies. Interesting, of the 4 participants at the baseline that at the enrollment already had antibodies detected, 2 of them developed a PCR confirmed infection during follow-up. Then of the PCR confirmed cases, most of them developed an immune response. So we were able to detect antibody response in all the PCR confirmed cases, except in 3 PCR confirmed cases. And we went to retest again the samples by PCR. So we do believe that they are true positive. So there was really an infection, but these individuals did not mount antibody response after infection. And something that we wanted to assess was the full force of infection. So we detected at the end of the follow-up 37 participants that had antibodies, although during the follow-up period they were tested in nasal swabs, but they did not have any PCR confirmed infection. So we don't know if these were just milder infections that we missed, or as we all know, also that PCR is not 100% sensitive. Then comparing them, we asked the participants when they were coming for visits, we prompt them for symptoms, and we had in total of the PCR confirmed case, there were 14 that were totally asymptomatic, so they did not report symptoms at the day that they tested COVID positive, and they did not report symptoms during follow-up. There were 80 participants that had symptoms at diagnosis, and then 41 that developed symptoms in the week following diagnosis. And the most common symptom was cough, and then followed by impaired sense, taste, or smell. So one of our objectives was really to look at symptomatic and asymptomatic participants, and to look at the viral load if it was different by symptomatology. And what we saw is that the mean PCR CT value was higher in asymptomatic participants. So meaning that participants that were asymptomatic had a lower viral load compared to symptomatic participants. Another objective of the study was to look for the length of viral shedding, and we observed that the mean duration of viral shedding was about 18 to 19 days, and symptomatic participants, so participants that when they tested COVID positive, they displayed symptoms, they shedded the virus for a longer time compared to healthcare workers that never developed symptoms. So these are really the first results of our study, and I think because of this session is about new questions and what else can we learn with our study. So like I mentioned in the beginning, we are continuing following up this cohort, and especially what we are really interested at this stage is to look for reinfections. So we really want to see if participants that have been already infected during the first wave in South Africa will get reinfected. In South Africa, as I think someone mentioned yesterday, healthcare workers started to be vaccinated about a month ago, and we were wondering, this is just a small cohort, so it will probably not be useful to look at vaccine effectiveness in this small cohort, but we could probably expand this study and involve more healthcare workers and look at vaccine effectiveness. And something that we are also very, very interested was to look at vaccine immune responses in relation to pre-immunity. And one of the essays that we are planning to do is also to look for cell-mediated immune response, like I said, with our collaborator in Paris. So the findings that I showed you today have been submitted at Clinical Infectious Diseases, and the manuscript is under review. And currently we are doing the serology testing for the longitudinal samples. So like I said, to look for waning of antibodies, and if there is any correlation between antibodies from the first wave to the second wave in South Africa. And I just would like to finish with a big thank you, especially, of course, to the participants in this study, and then to the big team, especially here at the hospital that was responsible for this study. Thank you.
Thank you, that was super. Over to you, Rebecca.
No, that was wonderful. Maybe before we go to the next presentation, just if there's any burning questions, I don't see any in the chat. I just wanted to congratulate you, Marta, and the entire team. This is incredibly valuable information, and especially given the fact that how shall I say, the huge variations in factors which influence have been influencing the outbreak across the region are quite substantial. This is an incredibly useful information and will be very important to compare with other locations. I don't see any burning questions, Gail. We can certainly move to the next presentation.
Yeah, please do.
Yeah, so this is for Dr. Francis, if you're present, on the immunocov cohort, which we also saw a video about earlier, which was absolutely wonderful. Yes. Francis, if you'd like to share your slides and perhaps start the presentation.
Yes, I'm trying to see whether I can share my slides.
Why don't you do that, and I'll try and encourage everyone who's attending this presentation, and even those that are not, to spend the time watching the video which was presented during the break.
Yeah, can you see any? Oh, so
That's okay, keep going.
Stop.
we see your very full desktop.
Oh, can you see my?
There you go.
Oh yeah, my PowerPoint. Okay, thanks.
Perfect.
Yeah, so my name is Francis, and I am at the KEMRI Wellcome Trust program in Kenya. So I'm working with this project called Immunocov, which is a collaboration between, obviously, EDCTP, the county government of Kilifi, where the main campus for the KEMRI Wellcome Trust program is. We have another campus in Nairobi. We are also working with the Aga Khan University, who have a hospital in Nairobi. And we have a collaboration with the Karolinska Institute in Stockholm, Sweden, and the Leiden University Medical Center. So as I said, my study is called Immunocov, and we are really just looking at the natural history of the infection, and our objectives are based on the fact that we believe that the immune response could explain some of the pathogenesis that is seen in severe COVID, or could also explain why some people are not getting symptoms at all. And so now it is actually quite clear that Africa, even though we still have the problem, we're getting a lot of disease. We are not suffering as much as the suffering that we've seen in Europe and in America. And we wonder whether that could also be explained biologically. And that actually also fits very well in this session for emerging themes. So in short, our initial objectives were to validate some serological and cellular assays, and then we would determine the kinetics of the immune response to SARS-CoV-2 in people who have been diagnosed as positive. And in this, we'll do by looking at blood and also saliva. And the idea about looking at saliva is that because we know that when I say saliva, actually I mean the oral fluid. So
looking at the oral pharyngeal fluid would be less invasive in future studies than taking, say, blood, for example. And we also plan to characterize infiltrates from, so immune infiltrates in lung fluid, especially in those individuals where it is possible to correct the sample. So we are working with clinicians who believe that if for the intubated patient, this is not a huge problem. So we, just like the other talk, we intend to look at the length of viral shedding. And obviously we are collecting the clinical data. And the idea is to correlate, to measure correlations between the length of viral shedding and also the clinical symptoms, especially the degrees of these clinical symptoms with the immune kinetics that we're talking about. So our study, because it's longitudinal, would also be able to show the longevity of the immune response. And we also hope to look at antibody function. And with antibody function, we'll be looking at neutralizing antibodies, we look at complement function, and then select individuals with good antibody function where we can make monoclonal antibodies that we characterize further. And as stated before, we have an aspiration, and we're working actually with our European partners in Sweden and also in Oxford to see whether we can compare some of the aspects of the COVID patients that we're getting and also asymptomatic individuals between Kenyans and Europeans. So this is the design of the study. It's longitudinal, as I suggested, and the hope that is that we will be able to recruit individuals that represent the three disease categories highlighted here. That is asymptomatic infections, people with severe disease, and individuals with mild disease. And then obviously our analysis will involve measuring correlations, whatever correlations between those degrees of severity in terms of disease with the immune measurements that we're doing. So specifically, most of our samples, especially for severe disease, are coming from the Aga Khan Hospital in Nairobi. So Kilifi is more of a smaller town, more of it's not a big urban setting. And interestingly, we are not really seeing a lot of severe disease here. So most of the individuals that we're recruiting in Kilifi are with mild symptoms, and sometimes we're lucky to find people with asymptomatic infections. So this is just shows the range of the samples that we are taking. So really, so I suppose the things to highlight there is that we, as I will mention a bit later on, as also an additional measurement, we've decided also to include, to look at vitamin D and iron deficiencies, because we know those are two deficiencies that could affect immune function. So we will also be relating those to immune function in the individuals that are responding to COVID. So yeah, so this study has had a lot of challenges, as you can imagine. So because we are recruiting people who are already infected, so we have to wait for the people to be infected and then recruit them. So apart from maybe the challenges of delayed regulatory reviews like ethics and getting government permits, so it's been a bit more difficult to recruit the individuals in Kilifi County because, as I said, most of these individuals will be mildly sick, and so they're not admitted in hospital, and the government policy has been changing quite a bit. So we do have quite a number of samples now from for this prospective collection in Nairobi with the admitted patients, and we should be starting the analysis soon, but we are still lagging a bit behind in Kilifi, but actually that is happening. So, and because of those delays, we also became quite innovative. So we have been looking at other things that we could do with the resources that we have. So importantly, we have a huge collection of the clinical residual samples. You know, these are the samples that remain after clinical management of patients at the Aga Khan Hospital. And in some cases, these samples are available at different time points. There are no PBMCs, but there are plasma samples that we will use for the iron and the vitamin D measurements. We will also be able to do some analysis of the looking at HIV, but there are not many HIV cases. So the few HIV cases that will be there will also be analyzed and see what we find. So the other thing that we are very interested in is because in the area where we work in Kenya, we have these long-term cohorts that we use for malaria immunology. And we have obviously historical samples from these individuals, so that were taken pre-COVID. And so we plan to do also some post-COVID cross-sectional surveys. And then we would be able to work around those samples to look at the effect of potential cross-reactivities between SARS-CoV-2 and other coronaviruses. So, so this is a list, of course, of the sort of publications that we envisage that will come out of this work. Obviously, the list may change with time, but we do hope to be publishing the kinetics of the, especially the antibody and the cytokine responses in the COVID patients here in Kenya very soon, which will be followed by some detailed analysis of the cellular immune response. And then we have already a student who is actually working on the vitamin D and iron measurements. And so that is also, that is something that will come through quite soon. So we are in discussions, as I said, with our Swedish and collaborators from Oxford to see how best to do these comparisons. It's not very straightforward, but we have some hypotheses that, but that maybe because of either potentially cross-reacting, cross-protection with other viruses, or also increased immune regulation from the African population, that maybe this infection is not as inflammatory as it is with the European patients, but we'll see how to do that. So as I said, it is not a straightforward comparison, but we're working out how we could do that. So as I said, we will characterize the antibody function in all these individuals, and we'll select a few individuals where we will isolate monoclonal antibodies also for further characterization. And we should also be publishing on the longevity of the immunity in these individuals. We hope to collect samples for 2 years. That might be challenging because the study started quite late, and it's a 2-year study, but of course it's something that we can talk to EDCTP later. Yeah, and the other thing I haven't talked about is, so in my institute, we do actually, we do look at, we do sequencing. And so we are very interested in sequencing the viruses that will come from the individuals that we're recruiting, and also all those people who are being tested in Nairobi, especially at Aga Khan, because this is a private hospital that also hosts a lot of not just the Kenyan population, but also visitors, and it is likely to be a point of introduction for new variants in Kenya. So I will stop there. Thank you very much for listening to me.
Thank you very much, Francis. That was actually, I was just going to ask you a follow-up question because the sequencing was in gray, and I was going to urge you to look at that, but you very clearly responded. So that's wonderful news to hear, and of course, very, very important. I think we should probably move to our next presenter, which is Ayola from the CERMEL in Gabon. Armel, when you're ready, please go ahead.
I think it's bottom right.
Yes, sorry, I was muted, but I cannot find my way. Thank you very much for inviting me to give you an overview of our project, which is called EDCO. My name is Ayola Akimadeinka. As you have mentioned, I'm based at CERMEL here in Gabon. And then I will give you an overview of our activities on our consortium called EDCO, which means important data on COVID-19 profile in Africa. And this consortium composed of 6 institutions, 2 in Gabon, CERMEL, my institution, and the Faculty of Medicine in Libreville, IRI in Ethiopia, ARSF in Senegal, Leiden University Medical Center in the Netherlands, and the University Klinikum of Tübingen in Germany. So our idea on this project comes from the already existing data, as you can see here, the data presented by CDC Africa, which we follow every week, which indicated clearly the gap between countries and continents where the spread of COVID or severity are not merely distributed across the world. Our question is based on the African situation. As you know, and many of my predecessor speakers have highlighted the fact that in Africa, the severity is not compared to those in Europe, or even within Africa. There's a big difference if you compare Africa, Sub-Saharan African, and the northern part of Africa or southern part of Africa. The situations are completely different, and this is questionable, and to understand how come we can have this kind of discrepancy within the continent. I'm sure even within the country, we may have such differences. Based on that, we have we thought that there's a need to generate data on COVID-19 profile in Africa. Then this will help us to better understand what is going on, to understand the gap on this pandemic. As you know, Africa is poor and weak, with a weak health system. A difficulty in applying social distancing, which is the major measure against COVID-19. Lack of water for hand washing, which is another measure. High population density, urban area households, and also young population may be also another factors. High communicable diseases, when we talk about other diseases, this has been mentioned today. We have HIV, tuberculosis, malaria, all of this can contribute, and less non-communicable diseases based on available data. So the objective of EDCO study is to determine the clinical outcome of COVID-19 infection in 3 African countries, including Ethiopia, Gabon, and Senegal. Also to determine the pattern of virus transmission and the infection in household of confirmed cases, map the factors associated with COVID-19 infection and the disease progression, scale up capacity for case and household contact studies, and to establish a biobank which will help to better study the mechanism of transmission in Africa. Our study outcome are as follows. The primary outcome is the clinical cause of COVID-19 in African setting, transmission pattern within household of admitted COVID-19 patient. The secondary outcome is the association of inflammation and disease severity, which is questionable as mentioned by Francis. The biobanking for future biomarker measurement will be our pillar on this project because we collect sample which we'll be analyzing in depth after looking for additional funds. So far, what you can say that is the design of the study and the sample size. Our study is a prospective and longitudinal observational study of COVID-19 hospitalized patients as well as the household contact in 3 urban areas in West Africa: Dakar, Senegal, Central Libreville, Lambaréné, Gabon, and the eastern part of Africa in Ethiopia. As you can see, the inclusion criteria mean we need to have patients with PCR testing positive for SARS-CoV-2, and also the patient who is tested, and we have to contact the household contact. It's not the contact on the community, but the contact in the household, the person with who the index case do not make a clear distancing. That means there's a close contact with the household. So they will provide of informed consent, of course. We deliberately decided to exclude pregnant women in aim to comply, to increase the compliance in the study. And also this has been raised by ethical committees. So which data are we going to collect? The data which has been collected, which will be collected are demographic and anthropological data, clinical parameters, including temperature, pulse, hyper pressure, and also drug intake for other alignment diseases, inflammation marker, and also we try to address some questionnaire to collect information on knowledge, attitude, and then knowledge, attitude, and the practice for the on COVID-19. So for biobanking sampling, we will collect blood, and for the blood and nasal sampling, and also urine and stool sample will be collected and stored for the future study, which will also be part of a capacity building because we aim our students in different sites to continue this work after the funding of EDCTP is over. We try to look for extra funding, even from EDCTP if possible, for students to join together, to work together to better understand the mechanism underlying COVID-19, particularly when Africa is concerned. So the EDCO despite that, we have a substantial delay to start our study. And this is mainly due to the curfew. As you know, most countries in Africa have the curfews. For instance, in Gabon, we have a curfew starting, I would say, since March 2020. Then we are able to work some time. In Senegal, it's the same thing. And so some few delay has been seen for approval from some sites, especially in Ethiopia, and also the international travel restriction, which completely block the start and delay substantially the start of study and the procurement for study starting, including consumable and reagent and training from our partner from Europe to travel to Africa, or for African students to go to Europe. This is quite a substantial problem which we need to address. We have to address at some stage. So far, what have been completed, and the protocol has been approved, and the respective ID from each country has been completed. Authorization has been given from Minister of Health. Training of different aspects of study were conducted remotely, and still ongoing. Procurement of consumable has been started, and this is still ongoing. And we have we sensitized our community on this study, and there's a population. We're very happy to participate to such study, and they are keen to understand what is going on for COVID-19. Finally, we have started this project with in 2021, meaning we have more than 3 months of delay of starting study. From some side is even more than that. And this can be seen here on the sampling already collected. In Ethiopia, we have only 16 index cases so far and 5 household contacts. In Gabon, 75. Here we have 2 sites, which make us a more number compared to Ethiopia. And the Senegal, who we start earlier, have more NDES cases compared to other sites. This the data are still ongoing, and we hope to complete this by June, July, hopefully. So the challenge we have gotten this study, which we want to share with you, is important. And then if there is an idea to share with other consortium, will be interesting, is that we have reluctance of household contact of COVID-19 positive cases to participate in the study. This is due to the prejudice, stigmatization of people having when studying as visit at their house. The fear of COVID-19 exposure when they come to health facilities, access to severe cases, restriction. So to be keep in mind, this is the summary of a difficulty from site to site. It's not the same everywhere, but each site has their own difficulty, but we try to summarize them together. The technical difficulty in collecting nasal swabs sample, for instance, study participants find the nasorption and nasal swabs technique unpleasant, and therefore they don't give sample. This is something we have to work on it, and also affect the progression of our sampling, particularly when household contact is concerned. Training of study team for nasorption and nasal swab, which is also one component of our study, was being completely delayed or stopped in some sites, and the training is still ongoing, and this is because it's done through the video conference, which is very not, I mean, it's not well accepted by trainees. They really want to have face-to-face, and this has been raised as a big issue from our consortium, and then we hope that we will have occasion to do this training face-to-face if COVID-19 goes down, or if everybody gets vaccinated, and then we can be able to collect this crucial sample from participants to allow us to understand what is going on on the study. So I will stop here. We don't have clear data to present to you now, but I'm sure based on what we are collecting, interesting data will be shared soon and present to all of you. So thank you very much on behalf of the other member of the consortium, which are listed on this slide. Thank you very much, and looking forward to hear your question if there is any.
Thank you so much, Ayola. It's very interesting and important to hear. And I think now, Gail, would you like to introduce our panel, and then I can take over a little bit with some of the questions?
Yeah, that's fine, thank you. So 3 super presentations, and I've certainly taken down some notes myself, but if I could invite Christine Stabo-Ben to join as well, that's great. And I can see that Dr. Ben's got her camera on. So, and our 3 other speakers, if you feel comfortable and if your bandwidth is okay, if you'd like to switch your cameras on too, we'd love to see you. But understand if that's not possible. So we basically would, over approximately the next half hour, I'd love to hear more from you all about the key new emerging questions and knowledge gaps that you think are very specific to Sub-Saharan Africa regarding COVID-19. And perhaps I could ask Christine to start, and if she would like to start off by giving us a brief introduction of what she does and where she's from, that would be super. Thank you, Christine.
Thank you very much for the invitation to present our project and myself, and also first and foremost to thank the speakers for a great series of presentations so far. I'm Christine Ben. I'm currently in Mozambique, and I'm not there. It's for the first time. I usually work in Guinea-Bissau in West Africa, but we are here to initiate a multi-center randomized trial that is already ongoing in Guinea-Bissau, but we are now going to start with a considerable delay here in Mozambique, namely a study similar to the one that Dr. Dijken presented from South Africa, where we are going to look at BCG vaccine and whether that can alleviate the severity and potentially also reduce the incidence of COVID-19 and other infections. So we have as our main outcome overall infection risk. The delay has meant that actually it's going to be interesting to roll out BCG or to do the trial here in Mozambique, where the COVID vaccines are currently being rolled out, because that will give us an opportunity to look for potential synergies between the two vaccines, and particularly BCG has been shown to increase the antibody response to other vaccines. So that's something we will look into in this part of the trial, whether we can see enhanced antibody responses to the specific COVID vaccines if given together with or in close timing of the BCG vaccine. So this was a brief introduction of the project, which is with Cape Verde also, and with partners also from Lisbon. I myself is from University of Southern Denmark. I have one burning question, I guess, that I think is a knowledge gap, and one which is a bit of an elephant in the room, and that is with regards to vaccines and whether we should actually vaccinate in Africa. And the reason I'm bringing up this question that seems to be swimming against the current, so to speak, is that just a brief calculation shows that it will cost around $7.8 billion to vaccinate 60% of the African population. And as other people alluded to, Dr. Ngungu and the last speaker here also, the severity of COVID-19 in Africa has been thankfully much lesser than anticipated. And we have to compare the numbers of deaths, the 80,000 registered deaths with COVID-19 so far, with what we know are the serious mortality tax. So we have each day hunger killing more than 10,000 children. We have malaria killing 3,000 children every day, and over 1 million people die from malaria each year, most of them under 5 years of age. Around 700,000 people die from AIDS-related diseases just in a year, and almost 500,000 people from TB. So this should be compared with the death toll of COVID, and we should look at what is the overall, where do we get most health, overall health with the money. And I guess my fear here is that there is such a pressure from Europe, from North America to vaccinate the whole world's population, but basically we will be spending scarce resources from Africa on protecting elderly people in other parts of the world. So this is my take on an important question I think we need to address. Thank you for your attention.
Christine, that's an important question, and one which is perfect also for the other panelists to not only add to, perhaps they would like to add their opinion to the question you just raised, and also highlight maybe some other knowledge gaps. I think the next person, Marta, if you wouldn't mind, we'll just go back to the beginning of the agenda. Would you like to contribute a little bit in terms of the questions that are most pertinent that you see, and then also, if you feel appropriate, respond to Christine's comment?
Yeah, sure. So if I can just start responding to Christine. And Christine, I don't know if you were here for the previous session. So I think some of those issues were really raised in the previous session. So in Africa, where we have so many other pressing issues, kind of when we want to wait, what if we have a limited budget, right? Where are you going to put your bucks? And I think that really needs very, very careful planning. And I don't think there is an easy question or more to say easy answer, because it's now a lot of COVID is really putting such a heavy constraints in all the health systems that it's so hard to prioritize any other diseases, any other health priorities at the moment. And I think, in my opinion, I think we just need to learn how to live with COVID. I think COVID is going probably to stay for a while. And in settings like our African countries, I think we will just need to learn how to prioritize COVID and all the other pressing health issues that we have. And it's very different, I think, in other countries in Europe and in the US, the priority health issues are very different. So I think this needs to be a very regional dialogue that we need to have in the African region. but happy to continue the discussion. Then other pressing issues. So just because I'm in South Africa and I was just coming back from holidays when the new variant was discovered or was reported, I think that is really something that we need to pay attention to, the genetic surveillance for what is circulating at the moment. And again, there are countries that will have the ability to do that quite easily, and other countries that we don't know. So I know that now there are already some reports coming from other neighboring countries of South Africa regarding the prevalence of the new variant in those countries. But I think that needs to be more widely done, specifically when we'll start rolling out the vaccines, and it would be really, really important to understand what is the effect of the vaccines that are currently being rolled out in the protection against the different variants. And so in South Africa, I think we were quite lucky that we had different clinical trials performed here, different clinical trials that looked at the endpoint using different severity endpoints and looking at the different genomic background of the virus. So I think it could be really good to continue genetic surveillance in the African continent, because I think there is not much information about that. And lastly, for me, just because I do work on vaccines and I'm passionate about vaccines, I think we need to understand what are the bottlenecks in rolling out vaccines in Africa. And I think it's very different when we look at the vaccines that normally we use in all the countries. So normally are vaccines for the childhood population, for infants, and this probably the main target for COVID vaccination will be adults. And so we need different structures, we need a different way to communicate to reach this population. And in my view, we are not quite there yet. So I think it's good to have vaccines, it's good to have vaccines available, but it's good if we have great vaccines, but then people are not taking them, it's really not the effect. It will not be that important. So for me, I'll stop here and happy to continue the discussion. That this is very interesting. Thanks.
I just wanted to add one point on that, Marta, and also for other listeners. I don't want to vouch for the credibility of this, but I presume many of you have seen the Africa CDC report on the perception of COVID vaccines in 15 African countries. For those of you that haven't, it's certainly available on the website. It's very illuminating and speaks to many of the issues that Marta just pointed out, and the need perhaps to treat this on a much smaller spatial scale in terms of dealing with the barriers, which come not only from distribution, but certainly also in terms of acceptance and perception, not only with respect to COVID vaccines, but also with respect to the disease itself, which also speaks a little bit to what Christine was bringing up about whether this is perceived of as a priority, irrespective of whether it is epidemiologically or not. I jumped in front of Gail, I apologize. Gail, okay. At our last, I'd also like to make sure that Francis, you have a chance also to weigh in, both on some of the questions that both Marta and Christine raised, but also from your perspective.
Yes, I will start with Christine's provocative suggestion that we probably don't need to vaccinate in Africa. And I would say, yes, we need to vaccinate. And for two reasons. One is that even though not as many people are dying and suffering from severe disease in Africa as in Europe and America, there are still people dying, and any death is really regrettable. I mean, at the moment, actually, we in Kenya, we're going through this with what we're calling the third wave, and the hospitals in Nairobi are actually teeming with patients now. So even though we are saying that we have not observed as much death or devastation in Africa as Europe and America. We really don't know what the future is, because we also know that the virus is evolving. So I have had some people anecdotally suggest that the new wave is more lethal. So we'll wait and see what happens. And so I think we should vaccinate for that reason, to save lives. And the second reason as to why we should vaccinate also is, I mean, if we can reduce the transmission, maybe that also reduces the possibility of having a lot of virus floating around that is also evolving, you know, as, you know, maybe eventually, as Marta suggested, we'll probably have to live with it. But I think it would be unfortunate if Africans were denied access to these vaccines. I think we should get them, and everybody, you know, yeah. Yeah, but for my part, I think if the emerging questions, obviously, is one of the questions is where are these variants coming from? So I would be very interested in, so the idea of looking at, so actually there are some case reports in the UK now that suggests that where people have looked at, have sequenced the virus over time in individuals who are immunosuppressed. And actually they did actually observe emerging viruses, emerging variants in the same individuals looked over time. And so I think for me, one emerging question is asking, you know, these new variants being brewed in specific groups of people within the population. Say, for example, the immunosuppressed individuals who are likely to remain virus positive for a long time. And the other question that I think would be of relevance is on the question of vaccine effectiveness. So at the moment, we imagine that the AstraZeneca vaccine was only less effective in South Africa compared to elsewhere because of the new variants. But actually, there's also a real possibility that differences in population backgrounds may affect vaccine efficacy. So, like for those of us who work in malaria, we know that if you could actually have a new vaccine that works perfectly well with within a human challenge model with live malaria in America or in Europe, but when you bring that vaccine in an African population that has lived with malaria for a long time, those vaccines do not work as well. So on top of the variants, there will be other possibilities. You know, some of them may have to do with the fact that some of us have lived for a very long time with a lot of inflammatory infections. And so our immune systems have learned, have adapted to dampen that inflammation to protect us from dying, but that also makes it difficult to immunize us. And of course, one for me also is just what are the differences between Africa and Europe that could be responsible for the reduced frequency of severe disease and death. Thank you.
Thank you, Francis. That's a very important contribution. Before we open it up to a larger discussion, it's important that Dr. Ayola has a chance also to weigh in.
Thank you very much. Of course, I will start from where Francis stopped and the others, and then to raise the concern regarding the death, the number of deaths in Africa and compared to Europe and so on, and for which it's difficult to say currently if there's less death in Africa compared to Europe or US. We don't know normally how many people normally die really for COVID. I don't know how it's recorded. And then we can see through the second wave that we have more cases because we have more tools to perform diagnostic. So people dying, we don't have any data on that. As in Europe, there's SS studies. We show clearly that Germany performed very well. This is based on the number of the deaths per period compared to the previous years. In Africa, we don't know who is dying. It's the same. Is it the same demographic characteristic of those dying now compared to those dying in Europe or in US? I would not be make it be more optimistic, as Ndungu want to be, but try to have the same strategy as everywhere in the world. And this made me jump also in the vaccine. The vaccination should vaccinate people. But the main question, Dr. Ndungu raised that also. What is the effectivity of a vaccine in the continent? We only have data from South Africa and then maybe from another part of Africa. I don't know if somebody has the data, the real data on clinical trial, vaccine trial in Africa, in Sub-Saharan Africa, I want to say, and to show that these vaccines are effective or very safe. Now we will take a vaccine. This opened the door for a new, a next of the opportunity is to strengthen the capacity for pharmacovigilance. That's the only thing we have to do now, at least for the existing vaccine, instead of saying that we don't vaccinate people, we should vaccinate people, but make sure that we do kind of subset studies to understand the immunogenicity, the immune responses of African people, and the context, taking into consideration, of course, other infections, as Ndungu said, and also nutritional status, urban, rural paradigm, and to see how this vaccine works in Africa. And since there is a question about the gap of research in Africa, I will say the gap is that there is no trials ongoing in Africa. We should encourage trials in Africa. EDCTP should make a call for the continent to evaluate even existing and the upcoming vaccine or drug in the continent to allow us to have the data specific to the continent, which is part of what we are doing on EDCO, for instance, to have what is going on in Africa. We don't have any data for that. And also another gap which is filled is the follow-up of the new variants. We can make it more popular. That's the genus, what to call it, the sequencing of the new variants should be done everywhere as it is for the PCR. Maybe it's 2 years earlier, maybe in 5 years or 2 or 5 years, you should be able to have sequencing, the sequencer everywhere in the continent to be able to follow all of these variants and to see how the new variant behave vis-a-vis the vaccine we are going to give to the population. There's a lot of things, a lot of gap which can be filled, and we should not limit it ourselves to what's going on only for diagnostic. We should go beyond, make a diagnostic and counting the people who are sick or those who are dying, but we should also understand this and also try to develop on the continent also the diagnostic tool, as Mohammed said in the previous section, and also why not to put in place to develop a pharmaceutical company locally who can also take the lead, which can take the lead on developing of a new product for not only for COVID, of course, to try to change. This will be an opportunity given by COVID to Africa, not only the curfew and so on, but also opportunity for us to operate our labs, to operate our pharmaceutical company and so on, to be able to be independent a bit. That's where I will stop.
Thank you, Ayola. I think that the best thing to do at this point is also maybe just to go back around to the panel members and see if anybody would like to respond to some of the statements they made. And you're certainly all welcome to put questions in the chat. I have one in addition to vaccines, not to get too political on everybody here, but we sort of all learn collectively from the questions that we ask, and how we frame those, of course, plays a big role in whether we're able to generate knowledge or not. And so one of the things which is interesting about this discussion is that we speak about Africa, which is really a geographical construct, right, that serves sort of social and political functions, but doesn't really accurately represent much of the variation, the complexity of our planet's second largest continent. And so what Marta raised in her presentation may not be at all reflective of other countries, certainly some countries in the Sahel, And what's interesting to me in this conversation is thinking about what we see is that regarding COVID-19, these differences abound, although the impacts, either direct or indirect, on all of the populations will unfortunately likely be the same. And so it's interesting to think about that and also contrast that with different ways that other continents are discussed. So I'll go back to Christine quickly just to see if you wanted to respond to any of these comments that have been made, to see if you wanted to add.
Yeah, thank you very much. I think there was absolutely some things I didn't make clear enough when I raised this, what I knew would be a bit of a provocative question, but I just want to make it very sure that I'm not going to say that Africans should, I think somebody said, be denied access to vaccines, which I mean would be absolutely horrible and absolutely wasn't part of the or what I wanted to express. And I also think it's extremely important to say that there are well-defined risk groups. We have no other disease which has such a span over age groups, and no doubt that elderly age groups are in a high risk. So I would not limit, I would definitely still think that there was a good cause for vaccinating people over a certain age and people with chronic diseases, but I'm questioning whether we need to vaccinate 60% of the African population as has been suggested. And I'm also doing that in the light that we actually have maybe conservatively 30% of the population that has already passed COVID, and we know that there is a good immunity after COVID. It's not, we don't know a lot about the longevity, but at least it suggests that at least for a year you are prevented. And if this virus is like any other virus we know, then you will be protected. If you had an asymptomatic course the first time, the likelihood that you would suddenly get severe ill if you get ill again is very much smaller, as would be the risk if you had symptomatic disease. You would normally go on to have some degree of immunity, even if there are mutations, which would mean that the disease would be milder next time you get it. So I think there's a good chance of making, not what Dr. Nunes talked about, what is the long-term prospect here. This could be another corona cold virus that is circulating in Africa, not causing harm, if we can protect those who are at risk for it right now. And likely there's a good chance that if you have attracted it as a child or a young person and you didn't get very ill from it there, then maybe you aren't even vulnerable when you get older. So, I mean, in Denmark, we vaccinate for influenza for the 65-year plus. It might be that we want to use these vaccines for elderly people in Africa too, but maybe we don't even need that. And I'm very, very interested in the resource question, because this is not like, should we do it or shouldn't we do it? It is which diseases are we taking resources away from if we are going to invest, and I put the number here, yeah, $6.8 billion US. This is going to indebt Africa for many years to come, and this will, no matter how we drive it away or turn around, it will take resources away from other pertinent health issues. And yeah, so I think I also, Dr. Nunes, you said about the constraints of the health system that forces us to do something, and there back to what you just mentioned before, Dr. Rice, this is also different from country to country in Africa, and I know that the countries that I've been working in Guinea-Bissau, for instance, we haven't had any serious constraint on the health system at any time point during this whole pandemic, with a number of around 3,000 cases and 46 deaths. This hasn't taken any toll on the hospital system. So maybe also a reason to say that this discussion might not be taken for the whole of Africa at once, but could be country to country specific. But again, I think we need to ask, I need at least to ask the question, is it necessary? Is it really necessary? And not just take it for granted.
Thank you, Christine. That's helpful to clarify and to add to your previous remarks. I just want to point out a comment about that was put in the chat from Dawit about being careful about our presumptions about lethality in Africa. I actually also wanted to just insist on that again about what we know and what we don't know, and how it's very difficult to make presumptions about that. I'll go back now to Marta.
Yeah, no, I think kind of in the end we are all more or less in agreement, but just raising different points. But you know, I totally agree that this resource issue needs to be very, very well analyzed, and it's not only in Africa again, and I'm saying Africa, I'm sorry, Rebecca, I totally agree with you, but in everywhere, even in Europe, we know that a lot of cancer patients, chronic patients, are also being delayed for their treatment because of COVID. But I do think that in countries where we have other infectious diseases that have much higher mortality, we need to be very careful with that. Then regarding your comment on, yeah, we say African is totally true. I think we should, for this particular issue and the issue that I raised about the genetic variability, we should probably talk about regions, countries that share borders, countries that, so what happened, for example, in Southern Africa is that even though the borders closed, there were still migrants crossing the borders illegally. And so now we know that in Botswana and Mozambique, in Eswatini, and I think in Zimbabwe, the new variant was already detected. So yeah, when I think we, for this type of viruses, for disease that know no borders, right? We can probably talk about regions and how easy is the spread of the disease. And I think even countries closing the borders and not allowing the massive traffic that we have during normal times, there is still transit of people between countries and between regions. So, for example, I know that countries like South Africa that closed the borders even internally, that we could not travel between provinces, and so I think instead of talking about countries, instead of talking about the continent, probably we do need to talk more about regions, or how easy it is to travel between those regions. And I think this is not only a geographical issue, but it's also, yeah, economic, and someone mentioned genetics. Yeah, could be that there are, predisposition for certain genetic factors that, and I know that there are some projects looking at that genetic variability and predisposition for more severe disease. But totally agree that yeah, we can't, Rebecca, we can't just pull Africa in the same basket and just.
Marta, and also for the other panelists, I just wanted to raise two things just to add on to that. And Marta mentioned the different genetic backgrounds, but also what was raised by Francis about sort of the chronic immune activation, which is a different scenario in many of these populations. But I also wanted just to mention to everyone, there's an interesting question in the chat. Nope. It was resolved. I apologize, or maybe not. And the question was about Tanzania and about, which is a very interesting question about the role that the recent death of the president plays in terms of any type of change with respect to prevention and management of COVID-19, either within Tanzania or in other countries across the continent. So I just wanted to add that if anybody has a comment to make. And please feel free to jump in. Otherwise, I'll pass pass things over back to Francis.
Okay, so can I just say that actually we don't know what killed the president in Tanzania. There is a lot of speculation on social media that he died of COVID, but actually the official statement cited some cardio, something to do with his heart or whatever. So we don't know. But obviously the fact that he was making statements that wild statements that would have made people not protect themselves from COVID or whatever will have an impact in the if the new administration takes a different tack, which is actually quite positive. I've seen a picture on Twitter today of the new president. I can't remember her name, but she was wearing a mask, and she is encouraging people to wear masks. So that will make a huge different. So yeah, and I also wanted to come back to what David said. For sure, we are not saying that COVID-19 is not real in Africa, because there are people who are dying in Africa. In Kenya, so far, we've lost about 2,000 people to COVID. But let's put that in perspective. Kenya has a population of 50 million people. And if you look at 2,000 and a population of 50 million, if you take a country in Europe with a similar population, I guarantee you the numbers of fatalities from COVID will be far much higher. I don't know how many multiplications. So it's the frequency of disease, of deaths from COVID will be higher in Europe or whatever. So again, it maybe also comes to what somebody said about the fact that Africa is not homogeneous. So maybe where a lot of people are dying in Africa are also places that are closer to Europe in terms of maybe exposure to environmental antigens or infections. For example, actually, it's interesting because I'm recruiting patients from Nairobi and in Kilifi, and we get a lot more severe disease and death in Nairobi. But in Kilifi, most of the people we have seen will either be asymptomatic or mildly sick. So there might also be some geographical differences within Africa. And there might also be certain pockets of the population, certain individuals, maybe people who are immunosuppressed or people with that. We know people with diabetes, even in Africa, are more susceptible to severe life-threatening COVID disease. Yeah. So the one thing that has not been mentioned, of course, and that we need to keep watch on is the fact that because for over a year now, we've been so preoccupied with the COVID. I am very sure this has disrupted the normal vaccination program. So we don't know what we're going to see in the years to come because of those who missed their measles jabs or whatever, tetanus. Well, tetanus maybe is not a big problem because there is not a lot of tetanus in the environment, but things like measles, that's a disease that should worry us. So I think that those of you who work with vaccines and are interested in this, in vaccines, it would be good to look at what the effect of having a disrupted EPI vaccination program will be in the coming years.
Absolutely, Francis. That is an important question, and the indirect effects of the pandemic will certainly be known for generations, probably. I'll just leave the last comment to Ayola, if you want to add anything.
Yeah, thank you very much, Christine. For what I want to add is that regarding the question based from the participant regarding the death, the passing away of the president of the Tanzania, if this will change something. From my point of view, this will change, but not too much, because what's happened in most of African countries, the lockdown was a disaster, and where they think that we will have more death caused by hunger compared to what can happen with COVID-19 if you lock down people. And also, the change will be people will be fear in the beginning, and later on they will resume to the bad behavior. This happened in Burundi, in US. We mentioned Brazil also. This all of this lead, or even UK, who does not take care of them. They don't protect themselves. There's a transparency in this country. When they are affected, they can tell people, okay, I have COVID, please take care. But in Africa, it's it's something to say that the president has COVID. But we know that most of all of these head of states are unfortunately affected by COVID and they're passing away. And that's the only data we have. We don't know, there's no data, publicly data on the quality of people dying in the continent. And it'd be interesting to see, are there more deaths in the capital compared to the rural area? For instance, here in Gabon, the Minister of Health reports every day, 3 times a week, the number of people passing away. I mean, for the public is enough. We can go in depth to know who died, but most of them come from Libreville. There's no death inside of the country. Lambaréné, where I am, from this first week, we have 7 deaths, and most of them come from Libreville, for instance. This year, in the second week, we have 1 death, and in other part of the Gabon, there's no report. Does that mean the disease is less severe in the rural area compared to the capital? This is a question you can ask to understand why there is this difference, because I mean the number is slightly the same. If you take it as a proportion of the number of the cases based on the size of the community of the population, we have a kind of the same number of infection. And also, if you go to our ICU here in Gabon, Lambaréné, it's nearly empty. While in Libreville, there is no space to hospitalize patients suffering from other diseases. It's a nightmare in Libreville. While inside we have several infected people, but few of them are admitted in the hospital, meaning it's less severe here or there in the rural area compared to Libreville. This is a question you can make. And coming to your comments regarding Africa, to take Africa as a geographical comment. Yeah, Africa is an example. For this COVID, everybody have a question regarding Africa. Why? Because everybody thinks that Africa will be a disaster, Africa will disappear, the health system is corrupt, and so everything, we all fear. And we are locked down completely. I was here, I travel every day, every week normally from Africa to Europe, but this year I can't, because everything has been locked down. We say, okay, that's the end. And we survive from it. Why? We don't have the same situation. This is something we want to understand. That part of our research question. I hope EDCTP will also, not only EDCTP, will also put money, then we can understand in depth what's going on. So the vaccine is also a problem. I mean, as I already said, vaccinate everybody in Africa. Don't question. There's no question, will this be the case or not? But in parallel, we should keep in mind that the efficacy of vaccine administered in Europe is not the same as the same vaccine in Europe doesn't give the same effectivity in Africa. I have done that through malaria vaccine. This is also for this diarrhea virus, also rotavirus is not the same efficacy, but we still give it, we can save the life of few or 10% or 20% of people is better than 0. We should vaccinate people, continue to improve the healthcare, to improve the vaccine administered in Africa compared to Europe. It's not the same. We are not the same, and we should take this as the start of the question.
Mm-hmm. Thank you, Ayola. I'll make a small plug for that also, for more trials in Sub-Saharan Africa, not just on vaccines, but on everything else, given that this is an EDCTP sponsored forum. And also, Ayola, I was going to say, even to go further in your point, what one trial in Africa is not enough. It doesn't reflect adequately the diversity of populations. And so I would even argue that we should do even more. And I'll just hand it over to Gail if you want to wrap up and introduce our closing speaker.
Thank you very much. My goodness, what a rich panel discussion. That's one of the best I've been at for a long, long time. So bear with me. I'm going to try and do you some justice. I think one of the things to say is whenever I've been involved with emerging pathogen outbreaks over the past 2 decades, I've always found myself humbled. And I think many people around the world would share that feeling of humility when it comes to SARS-CoV-2. I think there remains, and it's clear from listening to you all, how much uncertainty actually still exists around this virus and around the impact of it. Yes, we have an armory of non-pharmaceutical interventions, and we have some of the results, positive results, for example, from the recovery trial, and we have some effective vaccines. But how long will all of that last? And will it differ in parts of the world, and will it differ country to country? And I think your point about Africa being heterogeneous as well plays out for Europe. And that can vary from how many beds are available in hospitals, how many healthcare workers are available, different approaches of the populations regarding vaccine hesitancy. But I think what we have all realized is just how fragile our world is, and how fragile our healthcare systems are, even perhaps in the slightly arrogant West. And I think I can say that because I'm based in Scotland. And I think we've all been humbled. I think there's a real opportunity going forward. And to quote the Secretary General of the International Federation for the Red Cross, that it's not just about building back fairer. He wants to see building forward fairer. And certainly when I've been speaking to the media and others here in the UK, I've always emphasised the need and the importance for COVAX, and that, you know, many of us believe we're not all going to be safe until we are all safe. I've been involved with a patient group of over 30,000 patients with long COVID around the world, including children. And certainly some of the work done by ISRIC and others is starting to make us realise just how many people are left with symptoms, for example, breathlessness and fatigue, a number of months after their infection, and they may never have been in hospital in the first place. And at a long COVID forum back in December, I was bold enough to suggest, could it become the pandemic on the pandemic? And actually, even a bigger threat going forward, a longer term threat to our fragile healthcare systems. And I know that there are people with long COVID in all continents of the world, not just in the continent of Europe. And we have had deaths. Unfortunately, we have had a high death rate in the UK, as have some other countries around the world. And it has in the end affected all age groups. I agree. Yes, as we've discussed here, in some age groups more than others, but we had to quickly change the messaging in the UK to make our younger population realise that actually they could end up in hospital and intensive care too, and they must also take the precautions. But I think there is some hope. I think listening to your research studies and the work that you're doing and the work that you're planning and the work that you're aspiring to, if there was more funding available, gives us hope. I think some of that was captured in the United Nations Research Roadmap that was launched about 2 months ago. It's very socioeconomic focused, but actually it's all about health, and it's all about how research can give us better health going forward. And I think all the countries of the world could benefit from that. I think it's important, though, that you have a voice, no matter where you are in the world and which region you're in. And I thank Christine for being, bold enough to bring up a challenging question and to ask these difficult questions. So thank you, Christine, for doing that. And I think it's important that, for example, Jean-Marie, that the World Health Organization hear about some of these points and debates, and so that they can reflect on this and make sure our colleagues around the world have a voice, but also to make sure that the surveillance systems are strong enough to actually capture any of the deaths that may be occurring, even at a community level. And that's where potentially we have great capacity from some of the community volunteer organisations. And I know, for example, the Red Cross in Kenya has been very effective with their community healthcare workers. And I heard about the success of that just recently. I don't think I can do you justice by reiterating all the science that you're doing, but safe to say that I think listening about the biomarkers, for example, and that's also being done in a number of other countries around the world. I think just reflecting with Jean-Marie and Charles from the GLOPADAR perspective, who has a clinical trial network working group, we're very interested in reflecting on how clinical researchers can work more effectively together across continents, so that we can be trying to learn as quickly as we can from each other. And some of the recent WHO meetings that have been made public have been trying to do that. Regarding the variants and the genetic sequencing capacity, I couldn't agree with you more. And that's really been at the crux of my argument, other than equity. regarding COVAX and challenging the UK government, who has bought a lot of vaccines across a whole portfolio, that sooner as opposed to later, vaccines need to be shared with other countries, and that we have to get on top of this transmission at a global level to try and prevent variants developing that might result in vaccine escape. But I think as a researcher to a researcher, you highlighted a number of barriers that I would call peril barriers: political, ethical, administrative, logistical, and so on. And I think there's opportunity for groups like GLOPADAR, the consortium of funders, to learn about that, and for the funders like EDCTP to reflect on how they might try and facilitate the removal of those barriers, or at least try and mitigate them. So I think that's the best I can do. Forgive me if you feel as though I've not done you justice. And I'd like to now welcome Dr. Leonardo Samoa, who many of you probably know, and he is the High Representative for Africa for EDCTP. And so I welcome him and thank you all.
Thank you very much, Gail. Good afternoon, everybody. It's a pleasure always to be with all of you. And I think it is proper to congratulate ourselves for the success of this second edition of the webinar on EDCTP COVID-19 emergency funding mechanism, which had a double objective of sharing experiences on one hand and findings too. Progress in capacity development is taking place, and this is the main objective of the EDCTP, is precisely to develop a research capacity in Africa. But all of us agree that this is a long-term, should take a long-term perspective, which is true because we started this journey back in 2003 with EDCTP1. Now we are at the end of, closing to the end of EDCTP2, paving the way for EDCTP3. So we're taking that precisely this long-term perspective. And it should also be an integrated system-wide approach with strong partnerships. And this meeting has shown that these partnerships, strong partnerships, are happening. During EDCTP2, 229 African institutions have acquired better facilities. 167 fellows funded from 24 countries. 111 PhD students were funded, and 9,091 researchers and support staff received the short-term training from EDCTP fund, and 37 countries had their regulatory and ethics review committees trained. All this, the combination of these people, processes, and physical infrastructure is producing impressive research across the continent. And this meeting is a testimony of it. And the meeting has put in evidence that EDCTP was able to mobilize funding for 26 projects in a very short time. And strong partnerships through a consortia between institutions from the North and the Sub-Saharan Africa and between African institutions have been developed and are continuing to be developed with benefit for all. And this also is in line with the philosophy of the EDCTP. Priority groups, pregnant women and children, were not forgotten in many of our studies, but also we were able to look at communities, the challenges we face in communities, the challenge we face when working with the communities, but also we went even deeper into the household settings. It is true that many studies presented preliminary findings, but they are an important contribution for our better and increasing knowledge and understanding about the COVID-19 and its dynamics. But one important identified challenge was the need to develop genome sequencing capabilities in most African countries, as to avoid the need to send samples to labs in the north. On the other hand, with the improvement of living standards across the continent, it's true that we complain that they still have a higher rates of poverty, but there are progress happening, progress taking place. We see, and also with the success of the immunization programs, we see that parasitic and some bacterial diseases are in decline, but viral diseases are on the rise. And therefore, national health research institutions needed to upgrade their capabilities to successfully deal with these additional challenges. And genome sequencing capacity is one of these steps requiring our attention. I would say the same about mathematical modeling and other relevant techniques which are important to face this new challenge that I'm referring to. I'm sure EDCTP and other partners are taking note of these recent needs. But before I conclude, I want to extend a special thanks to the presenters, the panelists, and the chairs of the different sessions, all having made a great contribution for the success of our meeting. I also thank our colleagues of the EDCTP Secretariat in The Hague and in Cape Town, in particular Jean-Marie and Lucien. Lucien, we talk much about him, but Lucien is the IT specialist of EDCTP. I thank every one of you for participating in this session, and I declare the meeting closed. I thank you all.
Thank you.
Thank you.
Thanks.
Thank you.
Thank you very much, everyone.
Thank you.
Thank you.
Bye,
Everybody.
everyone.
Thank you.